Hello and welcome to PPMD's 27th annual conference and our second conference held all virtually. I'm Ryan Fisher, Chief Advocacy Officer at PPMD.
And I'm Eric Camino, PPMD's Vice President of Research and Clinical Innovation.
So here we are again. This is our second virtual conference. We of course wanted to be in person this year, but out of an abundance of caution, we decided to go virtual again. But it doesn't mean we don't have a robust agenda. We have a packed agenda for the next 4 days, don't we, Eric?
We do. So we have a number of things coming your way over the next 4 days. We have sessions on care and with a great quality of life and panel on awesomeness on our last day. We're going to bring you interviews with sponsors talking about their clinical trials, as well as some preclinical research updates as well. We also, for the first time, are going to have some recently reported updates at conference where a number of sponsors are presenting new data live at conference. We also have Pat with us in the studio this year, and she's going to do some deep dives on experts in the field on various topics. And then we have content on the conference hub, such as our poster session, pre-recorded videos that you can all kind of dive into at your leisure this week. We're also going to be doing some live polling and have some photo challenges for a little bit of interaction between us. And with that, I'm going to hand it back to Ryan to go over a little bit of housekeeping for conference.
So remember, everyone, to bookmark your virtual conference hub. This is going to be the place where you can find everything about conference. We have a library of pre-recorded videos from many of the sponsors and speakers that you're going to hear from over the next couple of days. You can also go there and register for one-on sessions with experts in behavior and learning. Our team from the Duchenne Registry, our certified Duchenne counselors, will do one-on-one sessions with you as well, and also physical therapists. You can also register for the Lunch and Learn sessions on an array of topics, and then our Zoom social nights, which will take place over the next couple of nights. Finally, we have a daily virtual photo challenge that we hope everyone's going to participate in. I think this day's theme is Wacky Day, and the winner of that photo challenge will be a $25 gift card. So if you have questions or comments, any issues, you can email us at comments@parentprojectmd.org. Also, any questions for the panelists or the speakers, there's going to be a box where you can submit your questions in real time. It's going to be below your player, so make sure to do so. We'll get to as many questions as possible. So Eric, what do we got up today?
We have a lot in store this evening. We have 2 Into the Pipeline sessions, and those are our series where we talk with sponsors about their clinical trials. So we're going to be talking about some sponsors looking for investigational products at restoring dystrophin, as well as some approved products, and a session on protecting the muscle. In addition to that, we have a roundtable discussion on the power of advocacy. We're also going to have our first recently reported update, where we'll be joined by Dr. Paula Clemens to talk about some recently reported data from NSfarma. And then, of course, like Ryan said, we're going to have our pop quiz. We're going to have a look at some of those photo challenge submissions and a little bit of fun with that. But before we begin, we're going to have a short message from our board chairman, Anessa Faisenfeld.
Welcome to PPMD's 2021 Virtual Annual Conference. My name is Anessa Faisenfeld, and I'm Board Chair of Parent Project Muscular Dystrophy. I am so pleased you've joined us this week. And while we will miss our face-to-face interactions, hugging our friends, old and new, and, well, let's be honest, socializing down at the pool or meeting at the bar to download after a long day of panels and sessions, we recognize that now just isn't the time to take risks. But we do see safer days ahead, and I really look forward to gathering together with all of you very soon. Friends, what a year it's been, and together we've kept forging ahead because our work goes beyond just a virus. We have a life-altering mission to fulfill and a momentum in our community that, well, it just can't be stopped. We may be physically separated this year, but our voices have been heard, and the collaboration and progress that has continued across all of PPMD's areas of focus, from research, our care, advocacy, and even connecting our community. You know, if anyone knows how to survive and do our best to thrive, even when things get really hard, well, I think it's all of us. We're resilient. We did get creative. We made a few pivots, and we all pitched in when and how we could. And while the work to end Duchenne, it didn't end. And in fact, I think it only gained momentum. When I think about all that we've overcome and accomplished together over this past year, I feel a lot of pride. And through it all, you've been there alongside us. We could feel it, we could see it, and you were all supporting our efforts in your own unique way. And for that, I want to say thank you. It may sound a little cliche, I suppose, but truly, we can't accomplish all that we do, and we wouldn't be who we are without all of you. When we ask, you don't hesitate. You step up to give and give generously, to fundraise, and do so very creatively this last year, and to advocate in record numbers at our virtual Fly-In at Advocacy Conference. You step up to encourage and connect, to care and advise one another. The list just goes on and on. We are only as strong as our community. And this year, more than ever, together, we showed the world our strength. I also want to recognize our amazing PPMD staff for their dedication and perseverance as they've navigated these past 12 months. Their tireless work, it didn't go unnoticed. And while it was expected, they handled this pandemic with grace. And we are very thankful for their commitment to our community. Well, we have an extraordinary online conference in store for you this week that will not only inform, but will also connect. You're about to have front row seats to engaging live panels featuring the latest research, clinical trials, approved therapies, care initiatives, quality of life issues, and so much more. There will be breakout sessions broken down according to age and covering multiple aspects of care, and even one-on-one interviews with experts. You're going to have access to on-demand presentations on research and care, and even a virtual poster session and resource fair that you should all explore. And don't forget that opportunity we had to make one-on-one private appointments with physical therapists, occupational therapists, genetic counselors, and other specialists. And last, there will be fun, interactive tracks and social opportunities for the whole family. Don't miss out. We miss our Duchenne family dearly, and we look forward to seeing all of you together in person sometime soon. But for now, we promise you a conference full of information, education, conversation, and community, and a conference that stands apart from all the rest and remains true to all you have come to expect from PPMD. Welcome.
Thank you, Inessa. We so appreciate your leadership, and we miss seeing you in person as well. Now we'll hear from PPMD's founder and president, Pat Furlong, who will be officially kicking off the conference. Pat?
Welcome, and thank you for joining PPMD's 27th annual conference. Boy, we wanted this to be in person this year, hoping the impact of the pandemic would be behind us. As the months unfolded following the 2020 virtual conference, we watched as things began to change. The Pfizer and Moderna vaccines received emergency use authorization from the FDA, and vaccines became available for all adults, followed by children 12 and older. We struggled with our decision to go virtual again in 2021, but without vaccinations for 12 and under, we felt the risk was too great. For this reason, we are virtual again in 2021. In addition, we consulted with infectious disease experts to understand what is known about the efficiency of the vaccine for immune-compromised individuals. The advice we received is that the degree of immunity for immune-compromised individuals is unknown, as we are in the early stages of understanding immunity to COVID-19 and its variants. More specifically, the durability of the vaccine is in at-risk populations is unknown. We know how much it means for all of us to gather face-to-face and to learn from experts and each other. However, we've learned a great deal from last year's conference. With more than 2,000 attendees, the reach of the conference was far and wide. People who otherwise could not have attended the in-person meeting participated. We had a range of voices from around the world. Global stakeholders from across industry, healthcare, and research joined the meeting. In addition, federal policymakers and FDA joined many of the sessions. So the upside to being virtual is the broad reach we can achieve again this year. We know this year seemed especially long. The isolation, fear, and worry about delays in research and clinical trials, but it did enable a couple of things. It demonstrated the expanded use of telemedicine, greater interest in decreasing the burden of clinical trials by developing tools for evaluation that could be implemented at home. We saw improvements in device capture, and the warp speed of vaccine development has accelerated interest in and development of the master protocol for Duchenne. Under our CARE program, we now have 28 certified Duchenne care centers, with 13 additional clinics going through the application process. And international interest continues to grow with the program. This year, the CDCC program awarded nearly $500,000 in grants to enable and encourage collaboration across centers. The Duchenne registry continues to grow rapidly, with more registrants being added daily. We are also partnering with clinics to integrate electronic medical records with patient-entered data. In addition, we built the Duchenne Outcomes Research Interchange to collect post-marketing data on approved therapies. This will help us better understand their long-term safety and effectiveness. In 2018, we initiated a partnership with New York State on newborn screening. The effort is progressing well, as babies are being screened and diagnosed while ensuring that families are supported. We intend to submit to the Registered Uniform Screening Panel, or RUSP, in 2022, with the goal of federal acceptance of newborn screening for Duchenne and Becker. Our hope is that one day, newborns will be diagnosed and soon after have access to safe and effective treatments. Our research agenda continues to be robust. It includes investing in the development of non-viral platforms for gene therapy, a focused initiative on biomarkers, and an increased emphasis on gene therapies that target the heart. We know the heart is a muscle too. It needs to be protected as function is maintained. In addition, we're providing support for Wellstone research centers, analysis of longitudinal cardiac MRI data, and support for collaborations focused on disease progression, like DRISC and CTAP. We're also working on the development of a patient-reported outcome measure in collaboration with the University of Rochester. It takes a village, and we're thrilled to collaborate with so many amazing partners on these efforts, including fellow Duchenne organizations. Next, we've had incredible results with our advocacy agenda. This year marked 20 years since the passage of the MD Care Act, landmark legislation that's led to increased federal research in Duchenne and Becker, the development of care considerations, and ultimately, companies taking early ideas into clinical testing. The congressionally directed medical research program at the DoD is now funding $10 million annually. And in 2022, we're hopeful your advocacy efforts will help increase it to $12 million. We worked with Congress to introduce the Benefit Act, ensuring the FDA is transparent about how they incorporate patient preferences into their decision-making. While we were not in DC this year, we held our advocacy conference virtually with more than 440 advocates. Recalling how this community came together 20 years ago to advocate for the MD Care Act, the results have been remarkable, with over $600 million invested in Duchenne. It was a tipping point that accelerated research and provided support to every therapy in development and in trial. Finally, we continue to engage the FDA CDER, the Center Responsible for Drugs, which has 5 approvals in Duchenne: Exondys 51, Amondys 45, Vyondys 53, Vilepso, and Emflaza. Also, we've been regularly engaging with CBER, the Center Responsible for Gene Therapy. You will hear from Dr. Celia Witten from CBER later in the conference. In 2014, we were the first patient group ever to write guidance for companies developing therapies in Duchenne. It was submitted to the FDA for consideration. The effort encouraged FDA to write their own guidance for Duchenne, which was finalized in 2018. With the progress made since 2014 and the advancement in gene therapy, we're now ready to update the community-led guidance. We will be providing the community an opportunity to participate in this process. It's been a year full of change, and PPMD has taken one more leap forward. Finally, we're excited to announce that on July 1st, PPMD is officially moving their main office to the Rare Hub in Washington, D.C. Research, care, policy, all of it will be based in our nation's capital. So with all of that, thank you for joining us this year. We'd like to recognize our elite sponsors, PTC Therapeutics, and our platinum sponsors, FibroGen, NSfarma, Pfizer, Serepta, and Wafra. Our mission remains as focused as ever. We can, we must, and we will end Duchenne. Welcome to the conference. And now back to you, Eric and Ryan.
Thank you, Pat. It's so great to have you in the studio with us this year. So I'm going to kick it to Eric, who's going to introduce the first session of conference.
Thanks, Ryan. Our first session of conference is going to be one of our Into the Pipeline series. So as many of you who were with us last year may remember, we asked all of our industry partners to do a 6-minute talk test, a format we had borrowed from our friends at Action Duchenne. This gives us an opportunity to get a quick highlight of some of these clinical trials or approved products while still having time for you to ask questions to the companies. If you do want to learn more about any of these trials or products, we do have longer videos that are on the Conference Hub that you can dive into at your leisure. As a new addition this year, we have Dr. Mena Scavina, who has recently joined the PPMD staff, will be providing an introduction to these topic areas. So this first talk is going to be about different products that are aimed at restoring the production of dystrophin in the body. And so we'll start with that introduction video from Mena.
Dystrophinopathies, which include Duchenne and Becker muscular dystrophy, are caused by a variant or change in the DMD gene, resulting in little or no production of the dystrophin protein. These changes can include deletions, duplications, or nonsense mutations that disrupt the reading frame, which is the instruction the body follows to make a protein. When the reading frame is disrupted, it prevents the production of that protein, in this case, dystrophin. Let's look at the reading frame as a sentence. DNA provides the instructions for the protein, essentially like the letters in a sentence. Depending on which letters are missing or duplicated, the sentence may be completely changed and not make any sense. Or it may make sense, but not exactly like the original sentence. Therefore, the instruction to make the protein is altered, and either no dystrophin or reduced dystrophin is produced. This is seen with deletions, duplications, or smaller point mutations. If a period appears prematurely, then the sentence is shortened and may not make any sense. This is seen with a type of point mutation called a nonsense mutation, which inserts a stop signal into the gene. Stop codon read-throughs allow us to ignore the premature period, complete the entire sentence, and produce protein. If letters are missing, called deletions, exon skipping allows some letters that border the original deletion to be skipped over to correct the sentence and allow some protein to be produced. Antisense oligonucleotide, or ASOs, are single-stranded pieces of DNA that are used to restore the reading frame through exon skipping. If we can restore the reading frame or correct the sentence, we can produce dystrophin again, although it may be modified. The protein may be smaller and the amount may be less than typical.
And joining us tonight for this first panel, we have Diane Berry from Serepta Therapeutics, Leslie Magnus from NSfarma, and Christian Werner from PTC Therapeutics. As a reminder, as these discussions go on, if you have questions or comments, you can submit them to that box below the live stream, and we'll try to get to as many of those questions in the live Q&A as we can. And with that, we can begin with Serepta. So Diane, whenever you're ready.
Thank you, Eric and Ryan. Can you hear me okay?
Yes.
Yes.
Great. Okay. Hello, everyone. I'm Diane Berry, and I am the Senior Vice President of Global Health Policy, Government, and Patient Affairs at Serepta Therapeutics. I want to thank PPMD for inviting us to participate in this panel today. I'm pleased to give you an update on Serepta's PMO exon skipping technology. I'm going to be relatively brief, so if you'd like to learn more, please view our pre-recorded PMO presentation in the conference's on-demand library, or just reach out to us directly. Next slide, please. Please understand that some of our updates may be forward-looking, meaning I may speak about our future goals and the potential of our therapies, things that haven't happened yet. And with that, there is risk and uncertainty related to such statements. Next slide. Serepta's experience in Duchenne runs deep, with over a decade of dedicated research and learning about the disease and what's important to patients, physicians, regulators, and payers. And in recent years, the breadth of our Duchenne pipeline has become unparalleled, spanning 3 distinct approaches. Our RNA platform, which includes our PMO and PPMO exon skipping technologies. This includes our 3 exon skipping products that are approved in the United States. We also have an active microdystrophin gene therapy clinical stage program and gene editing work in the early stages of development. If you're interested in learning more about our next generation PPMO or gene therapy development programs, we're addressing those in the live sessions over the course of this conference and also in videos in the on-demand library. Next slide. 3 of our PMO programs have been approved by the FDA in the US under accelerated approval. They aim to restore production of truncated dystrophin and slow disease progression. Eteplirsen is a PMO designed to skip exon 51. It was the first therapy approved in the US in 2016 to treat Duchenne and is intended to treat about 13% of the Duchenne population. Golodirsen in the middle here is a PMO designed to skip exon 53 and was approved in the US in December of 2019. And this PMO addresses another about 8% of individuals living with Duchenne. And casimersen is a PMO designed to skip exon 45. It was approved this past February, and we expect it to address another 8% of the Duchenne population. Together, these 3 PMOs are predicted to serve up to about 30% of the Duchenne community. Next slide, please. For patients and families who are interested in exploring access to our approved therapies, we have a team of case managers at the ready to help. Serepta Assist is our patient support program that helps patients navigate the process of starting and staying on approved Serepta therapies. Our case managers provide one-on-one personalized support to families to help with reimbursement support, financial assistance options, treatment logistics, and other treatment-related needs. You can reach out to us through the contact information listed here. Next slide. We are deeply committed to building a strong body of evidence for our PMO programs. We have 10+ years working in Duchenne research, hundreds of study participants across all PMO studies, and 15 PMO clinical trials. Participants have ranged from 6 months to adulthood. In our job of data generation and understanding the long-term benefits and risks of therapy doesn't end at approval. We continue to study our therapies and collect data post-approval through both clinical trials and real-world evidence studies. For example, we've been able to collect up to 7 years of follow-up data on eteplirsen-treated patients through real-world sources. We are thankful to the many participants, families, investigators, and site staff whose commitment and perseverance have made all this work possible as we continue to accumulate knowledge regarding the benefits and risks of our PMOs. We know we have a lot of work to do to develop treatment options for many more individuals with Duchenne and to advance the science and improve and build upon what's been accomplished to date. Next slide. I'd like to spend a moment sharing 2 ongoing late-stage PMO clinical trials. Essence is evaluating casimersen and golodirsen, and Mission is evaluating a high dose of eteplirsen, higher than the FDA-approved dose. Both fall under the umbrella of what we call post-marketing studies, agreed to with the FDA as part of the accelerated approval process. The goal of Essence is to evaluate the efficacy of casimersen and golodirsen compared to placebo in patients with Duchenne. As part of this study, we're collecting functional data as both primary and secondary outcome measures. Essence is no longer recruiting in the US, but it's currently enrolling in other parts of the world. As for Mission, its goal is twofold. Part A is to evaluate the safety and tolerability of higher doses of eteplirsen. We've enrolled this first cohort. And Part B is to select a high dose and compare its use with the 30 milligram per kilogram dose of eteplirsen. In addition to collecting safety and expression data, we're also collecting functional outcomes in this study. Next slide. As for next steps, we remain committed to continuing to support all U.S. patients receiving our PMO therapies, executing our ongoing post-marketing studies, and further building the body of evidence in support of our PMOs. We are continuing to collect and analyze data to inform next steps for subsequent exon skipping trials. This includes data not only from our PMO platform, but also from our PPMO exon skipping platform, which we will be speaking to in a live session on Saturday, or you can view our video in the on-demand library. We will continue to work with regulators to determine a streamlined development and regulatory path for exon skipping therapies that target the more rare mutations. And we'll be sharing our future development plans with the community when we have these further mapped. And the last slide, please. I just want to thank PPMD again for having me here to speak today, and I look forward to being able to respond to your questions. And if you have any questions we don't get to or comments after this session, please reach out to our patient affairs team at advocacy@serepta.com. Thank you.
Great. Diane, thank you so much, and thanks for being first out the gate. Never easy to do the presentation. I just want to do one follow-up question to some of your remarks. I know you mentioned you're collecting data in post-approval, so after patients get on drug to your approved products and sort of real-world evidence. I know PPMD is working to combine some of that data with you in our PRO registry. But can you talk a bit about what exactly you're looking at in real-world evidence and timelines for analysis on what's happening with these patients and really what may be challenges with collecting this type of data?
Sure. Yeah, no, happy to, Ryan. It's a great topic. There is so much attention these days and recognition, I think, on the importance of real-world data and real-world evidence. I think one thing you had mentioned, you had referred to specifically is our observational study that we're conducting through a registry on our approved PMO products at multiple centers in the U.S. This study in particular collects data that's collected in routine visits, so no special visits required or assessments in order to decrease the burden on patients and families. But this registry is really only one source of real-world data, really to help inform a better understanding of how our therapies work in the real world and capture the true experience of a patient as opposed to through controlled clinical trials. And what this means is really looking at data that tells how our treatment impacts patients' lives and well-being in a way that goes beyond just the traditional clinical measures. And this can be in the form of observational studies and registries, like I just mentioned, or electronic medical records, wearables, claims, and billing data. And we're exploring all of these data sources. We believe this type of data really is an important element to appreciating the overall comprehensive picture of benefits and risks that can supplement the clinical trials that we're doing, including post-marketing trials that we're required to conduct by FDA. And so our hope really is that real-world data and evidence can get to a point where it supports product approvals or can perhaps satisfy post-approval study requirements and certainly can help secure patient reimbursement for treatment. And so we have a lot of work going into this. And as I mentioned, a lot of attention FDA's building a framework that Congress called for under 21st Century Cures. Just yesterday, Congress introduced Cures 2.0, or a discussion draft anyway, and again, reinforcing that there is a really important role in place for real-world evidence in regulatory decision-making. So a lot of forward momentum. I think the COVID pandemic really highlighted the benefits and potential use of real-world evidence and really required a shift toward more virtual data collection methods. And that's likely to lead to improved data collection platforms. I can't really speak to, you asked about timelines. I can't really speak to timelines right now. I think, we're still in the early stages, collecting some of this data and really understanding the capabilities of the various types of real world data sources. And along with that, you asked about challenges. There are a number of challenges. I think some of the key ones really are center around data governance, how to preserve data security and patient privacy. Oftentimes there's incomplete data or there's variability in the measurement. And really, lastly, is really trying to figure out what is considered good quality data. And I'm sure you all have heard the adage, garbage in, garbage out. And so with real world data, it will only be good as the data source itself. So, we have to be really diligent to ensure the data is high quality and reliable in order to ensure it is usable.
Okay.
So, sorry, I hope I didn't take too long.
No, thank you so much. It's a big topic. We could potentially even circle back. So I'm going to turn now to our next speaker, Leslie Magnus from NSfarma. Leslie, are you ready to go? Oh, you might be on mute. There you go.
Yeah, but not anymore.
Okay, floor is yours.
Please. Great. Well, thank you. And hi, Eric and Ryan. Nice to see you again after one very long and complicated year since our last virtual meeting. But again, thank you to PPMD for hosting this very important forum. And thank you for giving NSfarma the opportunity to present some information about both the company and our compound Philtexo. If I could have the next slide, please, which is our forward-looking statement. So I'll leave that for just a minute. And then may I have the next slide, please? For those of you who may not be familiar with NSfarma just yet, NSfarma is the subsidiary of Nippon Shinyaku. We are based here in the US in Paramus, New Jersey. And our main area of focus is orphan rare diseases, specifically Duchenne muscular dystrophy. And with that in mind, we were the sponsors of the North American Phase 2 trial for Philtexo. And we are the sponsors of the global Phase 3 trial for Philtexo, also known as RACER 53. In addition to orphan rare diseases, we are beginning to broaden our platform with some work in the hematology oncology space. Our parent company, as I said, is Nippon Shinyaku. They're based in Kyoto, Japan, and they were founded in 1919, so they're over 100 years old. They have approximately 2,000 employees globally. And like NSfarma, they focus on drugs for rare diseases and also hematology oncology. And in addition, they also focus on urological and gynecological products. Next slide, please. This slide represents some of the key milestones that have occurred since 2017. I won't touch on all of them, but I do want to point out some of the major highlights. Importantly, in October 2019, we started RACER 53, which, as I said, is the Phase 3 global trial for Philtexo. In December 2019, we completed the new drug application submission to the FDA, which led to the approval of Philtexo, now known as Philtexo, in August of 2020. So just under a year ago, this product was approved in the US. Presently, we have information on our long-term data, it's interim functional data, which will be presented today at this conference. Come the future, we anticipate initiation of another trial with Philtexo, this one looking at exon skipping in both ambulatory and non-ambulatory patients, and patients who are over the age of 8. And also in the near future, we anticipate initiation of another exon skipping type, exon 44 skipping, as I said, in the near future. Next slide, please. So just a bit more about Philtexo or Philtexo. It's an antisense oligonucleotide, which we heard about earlier in this call, and it's designed to skip exon 53. So therefore, it is effective in patients who are exon 53 skipping amenable, who have deletions that you can see listed here, 43 to 52, 45 to 52, even 52 alone can be treated with Vilepso. In addition to this list that you see on the slide, there are many other deletions that may be treated with Vilepso, and so you should always consult with your physician and or genetic counselor to find out if your deletion is amenable to exon 53 skipping specifically. In our initial phase 2 study, we looked at treatment with Philtexo at 80 milligrams per kilogram per week, and this resulted in significant increases in dystrophin production. The mean dystrophin production in the group of 8 patients was approximately 6% of normal once they had completed 20 to 24 weeks of treatment. In addition to looking at this biomarker assay, we also looked at timed function tests, and those provided supportive evidence of treatment-related clinical improvement. And those patients in our Vilepso group were compared to both age-matched and steroid treatment-matched natural history controls from the Synergy DNHS cohort of patients. At the conclusion of this initial phase 2 study, all participants were given the opportunity to enroll in a long-term extension study that would continue to assess both clinical and safety outcomes. All 16 patients elected to remain in the study, and some patients are even continuing at this point in time. Next slide, please. On this slide, we look at a more granular level at the results from the primary endpoint, which was the dystrophin production after 20 to 24 weeks of therapy. As you can see from this graph, at week 25, the change from baseline in mean percentage of normal dystrophin was statistically significant for Vilepso, with an increase of 5.3% to an average of 5.9% of normal dystrophin. Further, all patients exhibited an increase in dystrophin over their original baseline levels, and all but one patient achieved a dystrophin level of at least a minimum of 3% of dystrophin. When we looked at the safety profile for this compound, there were no serious adverse events, no treatment-related serious adverse events. There were no discontinuations from the study due to adverse events, and no deaths occurred during the study. What the safety profile did show were patients who had not unexpected symptomatology, such as nasopharyngitis, cough, nasal congestion, confusions, arthralgia, diarrhea, and vomiting, mild to moderate in almost in all cases. Next slide, please. On this slide, we're looking at the primary endpoint of the long-term extension study. This is data that's been collected at up to 109 weeks, so over 2 years of therapy. In this group, we see that the patients who received Vilepso, and we're looking at time to stand in seconds, so this is the primary endpoint. We see that in blue are the patients who received Vilepso therapy over this 2-year time period. In gold, we see the patients who make up the historical control group. What we're seeing with the blue line is a maintenance, a continuation of the same time to stand in seconds throughout the course of this study, while the historical control group shows an increase in time to stand. Keep in mind that on this graph, improvement is shown by a decrease in numbers. So if the graph is going up, if the line is going up, that's a clinical deterioration. This data will be presented in great detail at our 8 p.m. session with Dr. Paula Clemens, and I hope everyone is able to participate and listen into that session. Next slide, please. So finally, I'd like to just review that Philtexo was approved in the US and in Japan, both in 2020. We're continuing to enroll patients in the phase 3 RACER 53 study. We do have an NS Patient Services Support Center. That number can be found on our Philtexo.com website. That is to assist both patients and healthcare professionals with questions that they may have. We anticipate initiation of an ambulatory and importantly non-ambulatory exon 53 skipping study in the near future. And we also anticipate initiation of an exon 44 skipping study. So please, for both of these, if you have an interest, continue to check regularly on clinicaltrials.gov, where we update very frequently. Thank you. Next slide is.
Just one follow-up question to your slides. Similar question to you that I gave to Diane. Now that you have an approved therapy with Philtexo, how are you tracking those patients that are on that approved therapy to understand long-term outcomes, efficacy, and safety ultimately? Is there a registry, or so what's the methods for that?
For the patients who are receiving commercial product, we do not have a registry at this moment. Of course, we passively receive spontaneous adverse events and collect those as per requirements of the FDA. So we would hear about those without a doubt, because these patients are being seen, even though they're not in a clinical trial, they're being seen every week at an infusion center at the time of their administration of the product. In addition, the patients that I've described from our 2-year data, many of them have gone on and are still in the study. So we'll have 3-year data when that completes. And now those patients are further being offered the opportunity to subsequently enroll in another long-term study where they will have periodic visits, and we will be collecting that data for 5 to 10 years of time from those same patients. So that will be a very rich data source of these patients who have been on Philtexo.
Okay, thank you very much. I'm sure we'll get into more discussion during the panel. We're going to switch now to Christian Warner from PTC. PTC Therapeutics has been in this community for many years, developing Ataluren and then bought Emflaza. Today, Christian's going to be talking about Ataluren. So I'm going to turn it now to Christian Warner.
Thank you very much, Eric and Ryan. Good afternoon, everybody. Thank you for the opportunity to talk to you today. My name is Christian Werner. I'm the DMD Therapeutic Area Lead working at Global Medical Affairs at PTC Therapeutics. And it's my pleasure to provide an update on Ataluren today, comparing data from Ataluren clinical studies with the Synergy Duchenne Natural History Study. Next slide, please. We are a public company, and this is PTC's forward-looking statement. Next slide, please. Ataluren is the first and only targeted medicinal product approved for the treatment of nonsense mutation Duchenne muscular dystrophy anywhere in the world. Currently, Ataluren is available in more than 40 countries worldwide, excluding the US, where it is an investigational product. Ataluren is indicated for the treatment of Duchenne muscular dystrophy resulting from a nonsense mutation in the dystrophin gene in ambulatory patients, age 2 years and older in the European member states, Iceland, Liechtenstein, Norway, Great Britain, Northern Ireland, Kazakhstan, Israel, and the Republic of Korea, and for patients 5 years and older in Chile, Brazil, and in the Ukraine. Next slide, please. PTC Therapeutics is conducting a post-approval registry called STRIDE to obtain information on the safety and effectiveness of Ataluren in routine clinical practice, where patients are followed up for 5 years. Data from the data cut in July 2018 showed 181 patients in the STRIDE registry that were statistically matched with 181 patients from the Synergy cohort who were comparable in established disease progression predictors. Ataluren plus standard of care in the registry was compared with standard of care alone in the Synergy Duchenne natural history study. Ataluren plus standard of care significantly delayed the median age at loss of ambulation by 3.5 years, which can be seen. The red graph is showing the patients treated with Ataluren in the STRIDE registry. The gray one are the patients from the Synergy cohort. Next slide, please. Looking at the non-ambulatory patients only, Ataluren-treated patients in the STRIDE registry showed a delayed lung function decline by around 3.1 years compared with matched Synergy patients, shown here for a data cut in January 2019. At this time point, 220 patients have been included in the STRIDE registry, coming from 58 sites in 14 countries worldwide. Next slide, please. Showing another study called Study 019. This was a phase 3 long-term multi-center international open-label study that included patients with nonsense mutation Duchenne muscular dystrophy who had received Ataluren in a prior PTC therapeutic sponsored study at investigational site outside the US. The primary objective was to assess the long-term safety and tolerability. In this study, patients were followed up for up to 240 weeks for efficacy assessments. This analysis showing a matching that was performed to identify Synergy Duchenne natural history patients compared to study 019 patients, again, a comparable in established predictors of disease progression. Ataluren-treated patients in this study showed a delayed loss of ambulation by around 2.2 years compared to the matched Synergy patients. Next slide, please. Same as before, looking at the non-ambulatory patients only, non-ambulatory patients treated with Ataluren in study 019 showed a delayed lung function decline by around 2.3 years compared to the matched Synergy Duchenne natural history patients. Last slide, please. If we summarize the data that we have seen data from the STRIDE registry, an ongoing observational study evaluating the real-world safety and effectiveness of Ataluren in patients with nonsense mutation DMD. As highlighted before, as of January 2019, 220 patients from 58 sites in 14 countries have been included. The second study I've shown, study 019, was a phase 3 long-term multi-center international open-label study to assess the long-term safety and efficacy. Overall, Ataluren was generally well tolerated and had a safety profile which is consistent with what has been shown in previous clinical trials. The matched analysis presented today were used to evaluate the effectiveness of Ataluren plus standard of care in the STRIDE registry or respectively study 019 compared to the standard of care alone in the Synergy cohort. Ataluren-treated patients in STRIDE showed a delayed loss of ambulation by around 3.5 years compared to the Synergy patients, and in study 019, a delay by around 2.2 years. Results also suggest that a trend toward delayed worsening of lung function for STRIDE and study 019 patients compared with those in the Synergy Duchenne natural history study. For further information about these studies and our ongoing clinical trials, please have a look at the pre-recorded presentation on the platform. Thank you for your attention. I also want to extend our thanks to the boys and families for their participation in the studies and to everyone involved in the conduct of these studies. Thank you. Back to you, Ryan and Eric.
Thank you so much, Christian. That was great. It's really interesting to see the data. We know that this is a requirement in Europe with EMA. We're hopeful, and we'll talk a bit about the U.S. side later in the panel. But one question I wanted to ask you was about sort of second-generation drugs for nonsense mutations or read-through drugs. We're seeing in exon skipping the move towards the next generation, so how to make them more efficient, looking at peptide conjugates, et cetera. I know families in the U.S. are wondering, with research in nonsense mutations, is there research for second generation, and is PTC looking at that type of research?
So, great question. So we are always looking to explore further opportunities and develop and advancing research in various therapeutic areas. So yes, there's definitely an interest in that, but there is, as of now, no compound that moved into the clinical stage so far.
Okay, thank you. I think we're going to now turn to the panel questions, right, Eric?
Yeah, so we've had some questions coming in from some of the families watching at home, so we're just going to kind of shoot those around to the panel. And the first one I'm going to direct at both Diane and Leslie is, we of course have interest from families about other exons that might be, in the pipeline. We obviously have had a lot of companies with focus on 51, 45, 53, some of the ones that have a kind of a larger share within the Duchenne population. What are the plans with your companies in terms of pipeline of these other exon skipping targets? And a follow-on to that as well is we've seen with Serepta and the Essence study where multiple exon skipping investigational products were kind of put under the umbrella in one trial. Are we looking at more trials like that where we can kind of move this along at a little bit of a faster pace rather than development of one at a time? And I'll start with you, Diane, and then we'll go to Leslie.
Sure. Another great question, Eric. So, I'll start off by saying, Serepta, we are 100% committed to developing medicines for 100% of the individuals living with Duchenne, and of which I believe up to 85% could benefit possibly from exon skipping. And so we definitely do have plans to expand into other exons. Like I said, we are looking at our data. We have to look at both our PMO platform and Ryan referenced next generation. So we have our PPMO platform. And so we really will have to make a decision with respect to which platform to carry forward. And so we certainly, as we develop those plans, will be communicating with the community. I do want to make reference because this community has been out in front with respect to looking for a streamlined path for, the more rare mutations. Going back over a decade, I remember talk of a platform type of approval. And so I think a lot of progress has been made over the years, particularly I referenced legislation. 21st Century Cures included a provision in there that really codified a regulatory foundation to be able to leverage data, in the situation where you're using a genetically targeted platform, across different candidates. And so, I think the regulatory foundation is there to develop a streamlined pathway for the more rare exons. I think, our data and the science needs to catch up. I think FDA is certainly open. And I think it really is incumbent upon us, the sponsors, to think creatively and do things like the master protocol trials and basket trials and things like that as we gain more evidence around our products. So I do have high hopes that we'll be able to go faster after these initial set of exons.
Fantastic. And Leslie, obviously you shared, exon 44 is coming. Does NSfarma have an idea of kind of what the next targets would be after that?
We're considering another compounds. We do have a library, a portfolio of compounds. So we are trying to make internal decisions about what would best fulfill unmet medical needs, what would be the best compound to then bring forward. But We expect to shorten the timelines between the rollout of these next compounds. So we're taking our learnings from the first compound that we took through the approval process, Philtexo, and we're applying that to exon 44 skipping and then subsequent compounds as they come up.
Okay, great. And as just a quick follow on that, and this might be a little bit early, but are you planning on maintaining that same 80 milligram dose that you had with Vilepso for your other products like Philtexo, or is that something you're still working on?
So it's a little too early to speak to that. We are looking at a variety of doses so that compound is already in the clinical trials in Japan. That's on clinicaltrials.gov. And it's in clinical trials in Japan. We're going to wait and see what the results from that look like in order to help guide us and steer us into the appropriate dosage for our US studies of the phase 2 program for that exon 44 skipping agent.
Okay, great. And Christian, of course, one of the questions that we've seen a couple of people comment with is, can you expand on kind of the regulatory filing status for Atelorin?
Sure, absolutely. So as I said in the presentation, Atelorin is so far an investigational medicinal product in the US still. We are in a continued discussion with the FDA on potential approval pathways. So more to come on this one.
Okay. And this one is for Diane. With regards to the Mission DMD study, could you expand a little bit on what those the high doses are that you're looking at in that trial?
Yeah, I don't believe we have spoken to the exact dose levels. It is significantly higher than the approved 30 mg per kg dose, and to unprecedented levels. So, yeah.
Okay, thank you.
Great, and we just want to thank all the panelists. We had a lot of questions come in. We are going to submit those to all the sponsors after the conference, and we appreciate your time today. We're going to now turn to introduce our first Pat Chat session. Pat's going to be talking with Dr. Eddie Smith. So Pat, handing it over to you now.
Thanks, Ryan. Thanks, Eric. I'm looking forward to hearing from Dr. Smith, as I think all of you are. Dr. Smith joins us from Duke University, where he's running multiple trials to include gene therapy trials. Dr. Smith, thank you for joining us. How are you this evening?
I'm doing great, Pat.
Good.
Thanks for having me.
Good. We so appreciate your time. So I don't know if you were able to listen in, but we've just talked about dystrophin-expressing therapies. And I'm going to back up before I ask you my question about that. But I think that, in the 2018 care considerations, what we saw is the mean age of death changed and added 10 years of life to these young boys. And that was employing known medical tools, steroids, steroid regimen, cardiac medicines, pulmonary care, physical therapy, et cetera. So with these dystrophin-expressing compounds, and certainly with the gene therapies, are you seeing the curve change as well? Are you seeing, as you see these patients, that things are once again changing toward better trajectory of longer ambulation, better pulmonary function tests for longer periods of time?
Wow. Well, Pat, my honest answer is I don't know at this point. I still think it's a bit early, and you're right. I mean, we've made strides with improved care and improved cardiopulmonary care in the absence of any dystrophin replacement. But of course, this is the big question. If we can begin to help our boys and young men make some form of dystrophin, some functional form of dystrophin in whatever amount, the hope would be that we would shift things even further over to the milder side, and then improve quality of life, improve function, or at least help maintain function even longer. There are a lot of factors that will figure into how effective that approach is. How much of the dystrophin does the treatment allow the boy to make? At what stage of Duchenne are you intervening? What's the condition of the muscle at the point when you introduce these treatments? And then also, very importantly, what is the quality of the dystrophin that a particular treatment allows a patient to make? We don't really have, when we talk about gene replacement therapy or exon skipping, it's really important to remember that these are not normal full-length dystrophin proteins that are being made. They're shortened versions, and they're going to be less effective than full-length dystrophin will be. And again, it's being introduced at some point well into the disease course. So I'm kind of jumping ahead. I don't think I answered your question very well, but these are the things that I think about. How much dystrophin, and what's the quality of that dystrophin, and what's the capacity of the muscle at that point in time when you introduce this treatment to respond to dystrophin, for that dystrophin to have something to latch onto and have a functional impact.
Yeah, I think it's so hard, right? And I think one of the other questions that parents are asking, in fact, just the other day I had a mom call who said, I have a young boy, gene therapy studies are underway. He's also amenable to exon 51 skipping. So how do I think about that, right? And how do you think about that in terms of, can you layer these therapies on? What would you need to know in order to think gene therapy and then an exon skipping product after that? What would you need to know as a clinician to be able to prescribe something like that?
Well, first and foremost is always safety, right? And I just based on what we know right now, I don't know why there would necessarily be a considerable safety concern by combining those two therapeutic approaches. In theory, they should work synergistically as well, and they're not going to combat each other. One will make mini or micro dystrophin, and the other will help make 51 skip dystrophin. One question I have, and I think many people have, is back to this quality question: is what's the quality of a skipped dystrophin? We know it's a much longer dystrophin protein than the mini or micro dystrophin that's being produced through gene replacement therapy. But those gene replacement therapy constructs were based on patients out in the world who had very short dystrophin molecules, but really relatively mild Becker muscular dystrophy. So the size of the protein is not the only thing, but it may be important. So I don't know the answer to that, Pat. I think we'll learn as we go. But at this point, I don't see a reason why they would be somehow mutually exclusive. One big hurdle, oftentimes, if you find the safety acceptable and think there might be a reasonable chance for additional benefit from combined therapy, is then getting it covered by a payer, right? And convincing, I'm talking outside of a trial, convincing a payer to pay for the two treatments together, because as we all know, these are not cheap therapies.
Yeah, I think we're all struggling with that, right?
Yeah.
I think that, obviously if you have one or the other therapy first or participate in a gene therapy, should there be approval, what are payers going to do to look at that therapy that will be incredibly expensive? Although from the parent side of things, getting dystrophin expressed is sort of like the holy grail, right? And then thinking about a gene therapy with a microdystrophin to add to or supplement or synergize with that dystrophin protein would be pretty incredible opportunity. Right. At least I think we'd all think that and hope it would really change what's happening in terms of progression. So we're working on newborn screening. I mean, I'm very hopeful there'll be a day when we can think about a baby and diagnosing very early and then intervening. I also think that, I worry a lot about the language we use, change Duchenne to Becker, because I think we're changing Duchenne, right? We want to get those three flavors of outcomes that you talk about, this slowing progression, stopping progression, or providing benefit. So would you treat a baby with a weekly antisense oligonucleotide?
I would. I think that we have a lot of progress yet to make with the ASOs, and there are so many promising and interesting programs in the pipeline that really seem to have potential to induce more exon skipping and then produce more dystrophin and then hopefully have more effect. My current thought is that that as far as dystrophin replacement strategies go, and this may end up being incorrect, but I'm more optimistic in the short term with gene replacement therapy approach in terms of amount of dystrophin, importantly amount of mini or micro dystrophin. That's one thing. It's one thing I always try to bring up. We talk about dystrophin replacement, but it's very important to remember that these are not normal dystrophin molecules. Mm-hmm. And to your point about Becker, it's well taken. We're learning to use this term dystrophinopathy, I think, more and more. In those terms, I guess what we would be talking about is shifting towards a milder form of dystrophinopathy. And the quality of the product and the quality of dystrophin that's made is key to that, but also, as you just mentioned, the age at which therapy is introduced. So I would not rule out prescribing exon skipping therapy to a patient. And if a family came to me and was very strongly pursuing that, I would not say no. I think many providers would not say no. But getting that approved, getting it covered, and it is potentially another story. I would also say that you mentioned a while back about exon skipping and in the era of gene therapy trials, and so for that family who has a boy who's exon 51 skip amenable, but also looking hard at trying to get into a gene replacement trial. Being on the exon skipping therapy is not necessarily exclusive. There were just, I think, the programs I'm aware of do allow a washout period. So the fact that you started or were on an exon skipping drug, but your child would have to come off of that to be eligible for the current slate of trials that are available or hopefully soon to be available.
But one day, hopefully, combination therapies, right, where we can treat with exon skipping or a microdystrophin and then lead right back into the next gene expression the next dystrophin expression therapy.
Well, I think it's right. And I think that there's some analogies here to the spinal muscular atrophy world. These are none of the things we're talking about are cures. I think we can talk about approaching that as we intervene earlier with more effective therapies, but there's always going to be that need and that desire to do more, and on top of the current standard of care. So I don't see any way around in the near future. I don't see any way around combining therapies. Again, not to harp on this, but I think the key at the end of all of this is going to be to convince payers to pay for that, and they will want to see evidence that additional treatment provides additional benefit on top of the baseline therapy.
Right. Well, we have to convince payers. We have to do the work that we need to do to see it and then convince payers. I'm so grateful for all you do. Thank you for spending time for us after probably a long and busy day. So we hope to see you next year in person. Thanks.
Likewise.
Yeah.
Thank you, Pat. Good to see you.
Good to see you as well. Thank you again.
Bye-bye.
Goodbye.
Bye.
Thank you, Dr. Smith, for joining us for that great conversation. We're going to briefly spotlight a few PPMD programs and be back with another in the pipeline series.
Hi, I'm Kathy Pinnett, advisor to the clinical care team at PPMD. We know how important school is, so I'd love to share with you some of the exciting school resources that we've been developing. Education Matters is a comprehensive 3-volume series that includes all the information that schools will need to help you and your student. When we're talking about behavior and learning, we all know that consistency is the key to success. Included in Education Matters are recommendations for both families and schools around behavior management, evaluation and management of special learning needs, establishing and maintaining independence, as well as everything that you will need to make your IEP or 504 meeting successful. You can download all 3 volumes from the PPMD website, or just let us know and we'll send you a hard copy. Duchenne is a really difficult diagnosis for young children to understand. To help explain Duchenne to young patients, their classmates, and friends, we've created What is Duchenne?, a short whiteboard video geared toward preschool and early elementary students. There are other videos, age-appropriate activities, and books to choose from as well on the Classroom Activities website. Last year, PPMD developed an exciting masterclass to educate medical providers unfamiliar with Duchenne and employees new to Duchenne Pharma about everything that they would need to care for people living with Duchenne. This year, we're proud to introduce a similar masterclass that will give schools and teachers information that they need. The masterclass for educators will be available later this summer, so please keep an eye out. Everyone should have received a pencil case and a business card for your next year's teacher in your conference supply box, as well as information that you and your school will need if there's ever an emergency. Having emergency materials as well as the PPMD emergency app available at your fingertips will give you all the emergency information that you'll need in one place. If there's anything else that you need or anything that you need more of, please let us know. We're more than happy to make sure that our families have everything that they need to make their next school year a huge success. Thanks.
The Duchenne Registry is an international registry for people who have Duchenne and Becker muscular dystrophy. Women who are carriers are also invited to join. A registry is a place to collect information or data about people who have a specific disease or condition. By sharing your data through the Duchenne Registry, you're joining a global effort to better understand Duchenne and Becker. Doctors and researchers use this data to improve care and develop better treatments. None of these people can do it alone. We need you. Join the Duchenne Registry through our new user-friendly smartphone app. Learn more about the app at duchenneregistry.org, where you can watch how-to videos to help you get started. Once in the app, you'll answer some surveys. Based on your answers, we can send emails about research studies you may qualify for, since many researchers use the registry for recruitment. Your privacy is important to us. Everything is stored securely. We never share your name or contact information. If you have registry questions, you can talk to one of our genetic counselors on the phone or by email. In addition to helping you with the registry, they can interpret genetic test reports and review the impact on your entire family. If anyone in your family needs genetic testing, our genetic counselors can coordinate free testing with your local doctor through our Decode Duchenne program. They can also discuss research opportunities and potential therapies. You have the power to make a difference. Join the Duchenne Registry and join the fight to end Duchenne.
Welcome back. Our next session in our In the Pipeline series is on protecting the muscle. But first, let's hear from Dr. Scavina about this important therapeutic area.
In Duchenne, the absence of the dystrophin protein means the muscle cell membrane is less stable than in a healthy muscle cell. Due to this instability, the muscle can be damaged, as there is less protection when undergoing normal mechanical stress during physical activity. This damage leads to a number of challenges to the muscle cells, including increased inflammation as a response to changes that occur from disruption in the cell membrane, and reduction in the ability of the muscle cells to repair themselves. Over time, the damage and lack of repair leads to the replacement of muscle with fat and fibrosis, or scar tissue. It also leads to muscle cell death. While there are multiple challenges that arise from the lack of dystrophin, it also means that there are many potential ways to treat the disease. These different downstream effects all have the potential to be treated by various compounds to help protect and strengthen the muscle, such as minimizing the amount of damage that occurs from normal muscle use, reducing the amount of fat and fibrosis infiltrating the muscle, improving the capacity of the muscle to repair itself, and minimizing inflammation. By targeting the various downstream effects, we can strengthen and protect the muscle and provide better outcomes for individuals with Duchenne and Becker, regardless of their genetic variant or change.
Thank you, Meina. Joining us for this evening's panel, Bassem El-Mankabadi from Fibrogen, Paolo Batica from NSfarma, Alan Russell from Edgewise Therapeutics, and Linda Marman from Capricor Therapeutics. Remember, for this discussion will be followed by an open Q&A. You can submit your questions in the question box underneath the player. We're going to begin with Dr. El-Mankabadi. Bassem?
Hi, thank you, Ryan and Eric, for introducing us here. I'm delighted on behalf of Fibrogen to be a part in this successful mission for PPMD, and we are thankful for you guys to invite us. So I'm going to go ahead and present my slides. So technically what we're talking here right now, let me minimize this, and we're going to go. We are delighted to have phase 3 started in our program. 2 studies for Duchenne muscular dystrophy. The first one is Lilantos 1, which is non-ambulatory patients. The slide that the first trials is the targeting age 12 and older for non-Duchenne muscular dystrophy. We are targeting 90 patients to be enrolled in these trials. The dose of pamrevlumab will be given in 35 milligram per kilogram in biweekly infusion for 52 weeks. And then patients who were randomized to the both arms will be given steroids in both arms. Standard of care is given in both arms. So the deflazacort or prednisone orally will be given in active arm, which the one that with pamrevlumab, and also with the placebo arm. After 1 year of randomization, all patients who decided to roll over into the open label extension trial will be given the pamrevlumab in an open setting, in addition to any approved therapy. So any approved therapy can be given to our patients in the OLE section. That's in regards to the non-ambulatory trial Duchenne. The next slides, please. I'm just saying the slides by memory now. I can't see it. But the primary endpoint is our performance of the upper limb, version 2. Changes from baseline to week 52. Our secondary endpoint divided into 3 categories. Actually, the first one is a pulmonary assessment, will be the change in the % predicted forced vital capacity, and also the peak expiratory flow from baseline to week 52. The second category here is the performance. We're going to test the strength of the hands, which is the grip strength. The change from baseline to week 52. The third assessment will be the cardiac evaluation, which will be ejection fraction, left ventricular ejection fraction changes from baseline to week 52 assessed by MRI. Next slide, please. That's Lelantos. The safety, of course, will be assessed throughout the trials. And also, we have a bunch of exploratory endpoints. Will be the Duchenne video assessment, will be evaluated. The caregivers will record some video for our patients through our vendors that we hired here in FibroGen. That will tell us any significant changes while the patient occurring in the patient disease progression while the patient resting at home. So that will be an exploratory endpoint in addition to the gene LTB-before and dilated cardiomyopathy. And kudos to the FDA. Actually, they are the one who highlighted that to us during our meeting with them. And we are delighted to have it as an exploratory endpoint to study here in our trial. A bunch of MRIs has been moved to the exploratory endpoint, which is the cardiac fibrosis assessed by MRI, in addition to the muscle fibrosis by biceps brachii, especially the biceps brachii muscle fibrosis. That will be assessed by MRI. Next slide, please. So that's a talk. So let's change gear here to the Lelantos 2. Our second trial here is for ambulatory patients who are 6 to less than 12 years of age. The same concept will be a randomized trial for 1 year. And all patients who were decided to roll over into an open label extension will be given pamrevlumab in an open setting in addition to any approved therapy, including even gene therapy once it gets approved. So technically, it's just the placebo part will be the first year of randomization. The dose, as shown here in the slides, will be 35 milligram per kilogram bi-weekly infusion. Of course, the placebo arm will be matching placebo in addition to the steroid PO, deflazacort or systemic steroids. Again, all patients who decided to roll into OLE can be given pamrevlumab in addition to any approved therapy. Next slide. So our primary endpoint actually here is ambulatory assessment will be the North Star from baseline to week 52. Any change in that will be assessed. In a bunch of other ambulatory tests here, it's forced stair climb velocity, time to stand, and loss of ambulation. And again, loss of ambulation has been added based on the EMA feedback to us, and we decided to add it, and we agreed with them, and we changed a little bit in our exclusion criteria for this study specifically to match that, to add that loss of ambulation. So kudos to the EMA as well in that regards. Next slides. All right, in conclusion, so pamrevlumab mechanism of action can mitigate fibrotic changes in the muscles of the Duchenne patients. Pamrevlumab can potentially be used in a broad range of patients regardless of their genetic mutation. We don't have a specific genetic mutation to be enrolled in our trial. So any patients, all comers can come in. Our phase 3 clinical trials are evaluating the efficacy and safety of pamrevlumab are ongoing right now. And we are delighted to enroll a bunch of patients in these 2 trials. And we are on track on track to complete enrollment by the end of this year, hopefully mid next year. So again, thank you on behalf of FibroGen to invite FibroGen to present our milestone here for phase 3 clinical trials. If you have any question, the next slide showing my email, my team email, lelantos@fibrogen.com. Feel free to reach out to us at any time. We can help you to enroll. Thank you very much, PPMD.
Thank you, Bassem. I really appreciate that. One quick follow-up question. Are you thinking that these 2 studies will be sufficient to drive an NDA submission for regulatory approval?
Excellent question. And the answer is yes. And that's exactly what we agreed upon with our meetings with the health authorities. 2 trials, one in ambulatory, one in non-ambulatory, can be sufficient for BLA.
Wonderful. Thank you so much. Okay, we're going to turn to our next speaker, Alan Russell from Edgewise Therapeutics. You're up next.
Thanks very much. Thank you. For those astute people around me, I am not Joanne Donovan, our Chief Medical Officer. I'm Alan Russell, Chief Scientific Officer. She is my better, but you have to put up with me for a bit. And thanks a lot to PPMD for the invitation. We're really excited to tell you about a new therapy that's currently in early clinical trials, 5506, which is a protective muscle therapy for different types of muscular dystrophy patients. Next slide. This is our forward-looking statement. We are a public company, so we're obliged to put this up just to say that I will be making reference to events that haven't happened yet, and also to note that 5506 is an investigational therapy that has not been approved in any territory. Next slide. So in muscular dystrophy, when dystrophin is deficient or absent, such as in Duchenne or Becker muscular dystrophy, the stress of everyday use of muscles triggers muscle damage that eventually leads to loss of function. The myofibrils that make up muscle have important proteins in them called myosin. The interaction of myosin with other proteins causes muscle contraction, just the normal activity of muscle, and delivers power of muscles to conduct everyday activities. And I'll tell you why this is relevant in a couple of slides. Next slide. So our approach is to protect those most susceptible muscle fibers in different types of muscular dystrophy, the exemplars being Becker and Duchenne. So we are made of fast and slow skeletal muscle fibers. In dystrophic muscle, the fast muscle fibers are more susceptible to damage due to the lack of dystrophin. Okay, if you're interested in learning a little bit more about that, you can see my face talking again in the voluntary section. So within the PPMD website, there's me talking again in a more detailed way about these. We've designed an investigational therapy, 5506, that protects these fast muscle fibers. Your slow muscle fibers are not directly affected by 5506. And in animal models of muscular dystrophy, 5506 protects those fast fibers from injury, improving strength, limiting muscle wasting, and the long-term development of fibrosis, including cardiomyopathy. We believe that protecting fast fibers may prevent further muscle degeneration and slow progression of disease. A phase 1 trial is currently ongoing in unaffected adults. I'll tell you a little bit more about that and a little bit more about the target in the next slide. Next slide, please. So I mentioned this protein myosin, which is important for force development in muscle. In that graphic on the left-hand side, it makes that middle strip of the muscle. 5506 is specifically designed to selectively inhibit the myosin from fast fibers only. Okay, our goal is to limit myosin to a level that prevents breakdown, but not healthy contraction. So we hope to limit those susceptible fast fibers from injuring themselves, not affect the slow fibers, and not affect healthy contraction. That should allow you to do everyday activities, but without injuring the muscle. In animal models of dystrophinopathy, 5506 results in decreased CK and other biomarkers, as well as increased activity. And I'll show you just one little snippet of our preclinical data on the next slide. So we have done a lot of preclinical studies in different models, but probably the most complicated model that you can run is the dystrophic dog. You've seen much of this data with the AAV microdystrophins, for instance. In this case, what we did is we took symptomatic dogs with Duchenne muscular dystrophy, and we gave them short courses of either vehicle or 5506. And you can see two effects of the compound in the graphs below. So as you probably know, in Duchenne, the muscle injury biomarker creatine kinase is increased, and that's usually believed to be as a result of muscle damage. What we saw when we dosed the dogs with 5506 is a decrease in CK. We also observed a really interesting increase in habitual activity in these affected dogs. So these are pretty old dogs, and we saw an approximately 30% increase in habitual activity during the dosing period. So a combination of reduced injury and increased activity. Next slide. So this is just a review of what we have in 5506. It's a small molecule, once a day tablet or liquid suspension. Now, because we're taking a kind of mechanical approach to the disease, we're potentially appropriate for any age or any mutation in Becker or Duchenne muscular dystrophy. As I mentioned, a phase 1 study is ongoing in unaffected adults, and we're also enrolling patients with Becker for a short study to measure biomarkers and safety as part of that phase 1 study. We're currently planning a phase 2 study in adults and adolescents with Becker, as well as an open label extension to study those folks late down the road to begin next year. And we're planning studies of boys with Duchenne that we hope to start next year. As I mentioned, this structural approach potentially could also be used beyond Duchenne and Becker into some of the limb girdle and potentially other muscular dystrophies. Next slide. So thanks so much for your time. If you have any questions or comments, please contact the email below, info@edgewise.com. Thank you very much.
Great. Thank you so much, Alan. One brief follow-on question. As you're considering potential ways to measure efficacy, are you thinking about muscle MRI given the mechanism of your drug?
Yes. With any protective therapy, we're really interested in muscle injury biomarkers, so things like creatine kinase, right? But as you know, the world of MRI is really progressing very fast, particularly with the wonderful work done by the Imaging DMD folks over in Florida, and we hope to tap into that actively to look at changes over time with that biomarker.
Wonderful. Thank you so much, and it's always great to see new companies entering the space and introducing them to the community. It's wonderful. So we're going to turn to our next speaker, Paolo Batica from Pharma, who is ready to talk about givinostat.
Well, thanks PPMD for allowing Pharma to update the community on the status of the development of givinostat in Duchenne. First of all, my disclaimer, I'm a full-time employee of Pharma, that is the manufacturer of givinostat. Givinostat is currently in development for the treatment of Duchenne and Becker muscular dystrophies. It is not approved for sale in any country around the world, including the United States. And this presentation is really intended for dissemination and discussion of scientific information only. So, as you are now well aware, the lack of dystrophin, which is the key feature of Duchenne muscular dystrophy, is associated with a much more frequent injury and damage of the muscle cells. Not only that, the lack of dystrophin is also associated with an impairment in the repairing mechanism. Givinostat, which is a pan-HDAC inhibitor, is actually working by activating this muscle repair mechanism. And in particular, it reduces inflammation, it reduces fat and fibrosis replacement, and it increases muscle regeneration. So as a result of all this activity, in essence, givinostat counteracts all the events which are triggered in the muscle and in the outside matrix that are triggered by the lack of dystrophin. And these are all the processes that eventually lead to the muscle replacement by fat and by scars. And we actually have shown these effects not only in the preclinical studies, but actually also in the main part of our phase 2 study in Duchenne boys. In the Duchenne boys, we were able to show that 1 year of treatment of givinostat on top of steroids led to an increase in muscle fiber diameter, an increase in regenerative muscle fibers, and a decrease in tissue damage, inflammation, and fat replacement. The kids that actually were part of this study were asked to continue treatment, and all of them actually agreed to. And as a result of that, we have now 18 kids that have been on treatment with givinostat on top of steroids for more than 7 years. So we can now look at what givinostat might be doing on what we call the disease milestone. And also we can look at whether the counteracting of the muscle deterioration that I was mentioning before and that was shown in the histology could also be replicated in the MRI. The result is yes, we were able to show that 2 years of treatment with givinostat on top of steroids was associated to reduce fat infiltration in the thigh muscle measured by MRI. And also we were able to show in these studies after more than 7 years of treatment that the disease progression is actually delayed by givinostat, and in particular, the age at loss of ambulation was actually, the mean age was 16 years compared to the 13.5 years that has been published by the Synergy group a couple of years ago. We were also able to show in these studies and this patient that we can delay the decline in respiratory function. And if you want more details on all these studies, please go to the Pharma on demand video. Well, where are we in the development of givinostat? As you are probably aware, we are conducting a phase 3 pivotal study. The objective of the study is to demonstrate that givinostat can preserve muscle mass and delay the disease progression. And this is done by making a number of assessments throughout the study. The Forster climb is a primary endpoint of the study. And then we are actually conducting all the standard tests that you are probably very familiar with by now, such as the North Star, the time to rise, the 6-minute walk test. We are measuring strength. We are measuring the fatty infiltration by quantitative MRI. We are measuring pulmonary function and heart function. The design of the study is depicted there. So at the baseline, the kids who are 6 years and older on stable corticosteroids and able to walk are randomized to either givinostat or placebo in a 2-to-1 ratio. And they are then being followed for 18 months. And throughout the 18 months, we do all the assessment that I've listed before. And at the end of the study, then the kids that want to participate are allowed to move to the next study, which I'm going to show now, which is in essence a long-term safety study where all kids are receiving givinostat, so there is no placebo here. And the study objective is to evaluate the safety and tolerability of givinostat in the long term, but also to evaluate the long-term effect on the muscle function and strength. And depending on whether the participants are ambulatory or not, we are obviously measuring different tests, like the one which I mentioned before, 6-minute walk test, North Star, and Forster climb for the ambulant boys. For the non-ambulant boys, we are measuring the performance of the upper limb. So with regards to the regulatory path, you may recall that we had a webinar some time ago saying that the futility was actually passed. So we had an interim analysis to look at whether the study was futile. The answer from the independent data monitoring committee was that the study was not futile and so enrollment could continue. And last September, we have completed recruitment with 179 boys recruited, and we are expecting the final data by the end of second quarter 2022. So this slide is really to say that there are different developments that we are doing in muscular dystrophies. On one hand, givinostat is being tested not only in Duchenne, but also in Becker. And I will be presenting the top line results on Saturday. And we also have some discovery programs that hopefully will provide new molecules that can then move to the clinic soon. And with that, I would like really to thank all the DMD boys that took part in our studies and their families. and obviously also the Becker subject that took part in the phase 2 study, and the clinical sites that did an excellent job to carry on the studies, especially in this hard time of pandemic. And last but not least, all the patients' organizations which are listed there that have actually supported quite a lot. For any information you might want about the studies, please go to the clinicaltrials.gov with the code that you see there. And obviously, the other possibility is to send an email to the patient advocacy at italfarmaco.com. Thanks a lot.
Do you want to ask a follow-on question?
Sure. So as you've kind of moved past, could you give us some insight into kind of how many patients or you've had that have rolled over into your open label as you're kind of looking towards your 2023 data?
So we now have probably around 130, 140 patients that have completed the EPD study, and all of them except like 10 have rolled over into the open label study.
That's great. Thank you.
Wonderful. We are going to figure out how to make this up to you, Paolo. I very much apologize for the technical difficulties. We're going to move to our next speaker now is Linda Marban from Capricor. Linda, are you ready?
I'm ready.
Wonderful.
Can you show my slides, please, now? Thank you. We are developing a cell-based therapeutic called CAP-1002 to use in later stage DMD. I would like to thank PPMD for the opportunity to present to you today. Next slide, please. Capricor is a publicly traded, NASDAQ-listed company under the symbol CAPR, and this is our forward-looking statement slide. Next slide, please. CAP-1002 is an off-the-shelf cell-based therapeutic that is not a stem cell. It works by releasing exosomes after the cells are infused into the body. The exosomes travel to the site of injury and are immunomodulatory and anti-inflammatory, and also drive muscle cells back into the cell cycle, causing new muscle cells to be formed. Most importantly, they have been used in over 200 people in multiple clinical trials, and so far have shown no adverse safety signals and encouraging efficacy signals in treating all kinds of muscle dysfunction, including heart disease. We have conducted 2 clinical trials in DMD, HOPE Duchenne and HOPE 2. Both were focusing on addressing the cardiac and skeletal muscle function in later stage, primarily non-ambulant DMD subjects. HOPE 2 was a randomized, double-blind, placebo-controlled clinical trial open for enrollment at 9 DMD certified sites. We treated 20 patients in this clinical trial. Next slide. We have previously released preliminary top-line data shown here. The final data set has now been submitted for peer-reviewed publication. As previously presented, we had strong signals of efficacy. Shown here is the data from the PUL 2.0, which measures the function of the shoulders, arms, and hands, and is used primarily as a metric of disease progression in those that are non-ambulant. We see a 2.4-point difference in decline over 12 months in those treated with CAP-1002 versus those that received placebo, which could suggest delaying disease progression by greater than 1 year. FDA has said that they will accept the PUL as a primary efficacy endpoint for approval for CAP-1002. Next slide, please. We also saw marked improvements in cardiac function as measured by MRI. Ejection fraction is a gold standard measure of how the heart is functioning to meet the needs of the body. And what we see here for the first time is a statistically significant improvement in ejection fraction in those treated with CAP-1002 compared to placebo. This type of delay of progression in heart disease could be the first therapeutic in the DMD space that actually improves heart function, the decline of which can lead to great morbidity and even death. We also had a statistically significant improvement in the levels of CKMB, which is a validated biomarker of cardiac muscle cell damage. We are now making CAP-1002 available to all eligible participants in HOPE 2 in an open label extension study. Next slide, please. Shown here is a slide from a survey conducted a few years ago on DMD patients. As you can see on both of the patients and the parents panel, the ability to lean forward and sit back up is a critical component of quality of life. And in case you can't see it very well, it is shown as number 7 on the patient side and number 8 on the parent side. Next slide, please. In HOPE-2 open label extension, we decided to tackle the issue of clinical meaningfulness by following the patients using a novel measurement tool developed by Casimir, which was to measure the function of the patients living their own lives. Casimir uses in-home video assessments called DVA, custom designed by each patient and their family to track disease progression or attenuation with a therapeutic. Most of the patients in the open label extension study of HOPE-2 are participating in this Casimir substudy. Next slide, please.
We are recording Carter with a stuffed turtle under his left knee because it's painful for him to have his legs like this. So, when I say go, follow my instructions as I give them. If you get stuck, just say help, and I will stop filming to help you. Ready?
And tell me when
go.
it's done.
Sit up straight. Lean forward and then go back to sitting up straight.
Now we're going to play the second video.
When I say go, follow my instructions as I give them. If you get stuck, just say help and I will stop filming to help you. Ready, go. Sit up straight. Lean forward and then go back to sitting upright.
Okay, and we're back, and we're going to open it up for panel discussions. Thank you so much, Linda. Linda, did you have one more comment on that?
I do. I just want to say that it's now able to lean forward and sit back up. As I showed you from the survey, this is a very important component of quality of life. There are other videos that we are currently reviewing, and we will be presenting those to FDA as validation of the clinical effectiveness of CAP 1002. What we know is that people with DMD don't get better on their own over time. But mostly what I want to say is thank you to Carter, the young man who opened the doors to his life to let us see what he's doing there, and to all of the patients in our trials, past, present, and future, that are willing to let us study them to make the world better for all of you. So thank you.
Great.
Now you can open it for questions.
Thank you, Linda. And one clarifying question to that video. Can you just clarify how many weeks from baseline that second video was taken, given that there was a break in the time that they were on therapy again?
So the patient, he was videoed at baseline. That was the first video. Then he came in for his infusion. And then that was 10 to 12 weeks after the first infusion and just prior to the second infusion. So they're getting 4 infusions over time.
Okay.
Over 1 year.
Thank you so much. All right, Eric's going to open us up now for panel Q&A.
Yeah. So this first one that came in, and I'm going to direct this to both Paolo and Alan. Paolo, you've obviously already had some experience in this area, and Alan, it's going to be something that obviously Edgewise is thinking about. But it's in the space of a clinical trial, defining Duchenne versus Becker and how you're thinking about that. Is it just related to the mutation? Are you doing it with mutation and function, age a component? Just kind of walk us through kind of what you've been defining within your trials for those kind of separating those two populations. And Paolo, I'll start with you and what.
So, yeah. So as far as the inclusion in the 2 different studies for Duchenne, the inclusion was based on the diagnosis of Duchenne, the genetic diagnosis of Duchenne. The age was 6 and above. They, as I said, they could come into the study regardless of the genetic defect, so all comers. And they actually had to be on corticosteroids for a stable 6 months. Plus, they had some inclusion based on function at the beginning. For Becker, Also here, it was all comers. It was based on genetic diagnosis also in this case. And here we allowed patients that were adults, so 18 to 65, and they had to have a relatively maintained function based on a 6-minute walk distance between 200 and 450 meters.
Great, thank you. And
no problem.
Alan, how are you all kind of thinking about this?
So for our phase 1 study, we're including all individuals with a Becker diagnosis. There are limits based on age and functional status, which are fairly basic, but we're taking a pan approach at this stage.
Great, thank you. Basim, one of the things that you showed at the end was in your open label extension, patients are able to add on other approved therapies, which we're really excited about as we've talked about combination therapies. We do think is going to be a big way forward. Now with that, if those patients are on taking pamrevlumab as well as an exon skipping therapy, that's a lot of infusions. Are you allowing the use of ports within kind of the open label extension as just to kind of decrease burden on families?
Absolutely, that's an excellent question. Yeah, Portocast is allowed, and FibroGen will going to take care of the cost of this Portocast if needed. We left it for the PI discretion whether the patient can get the vein access, and we'll take it in a case by case, but we will take care of that. In terms of the infusion, we ask the investigator to just wait for 3 hours between any infusion. Once the patient in the OLE, they get pamrevlumab first and flush the line, then wait 3 hours, get the other infusion. It will be a long study visit, however, it's manageable.
Great, no, thank you. These are, definitely challenges that we're gonna face in the future, but those are kind of positive challenges if we have multiple therapies available. Linda, during that period where there was a little bit of a gap in the trial, that kind of a 9-month, were you able to continue following those patients and kind of learn about the changes from those who were able to be on therapy and then kind of gap in back onto CAP-1002?
Oh, no, we actually did not follow the patients during the gap, but what we'll have is their last study visit and then their baseline visit in the open label extension. And we're actually looking at that data right now. It's really exciting data. And what I can tell you is that we have an expanded access program that's going into place for our people in open label extension, because we're getting so many calls from people who want to be able to continue with CAP-1002. And so, the message itself is that the families are definitely seeing a difference in how their kids are feeling and functioning.
Great, thank you. Alan, as you have talked about with Edgewise's product aiming to protect fast twitch muscles, is this going to be a therapy where especially early treatment and early intervention is going to be more beneficial? And is there potentially a threshold as we do accumulate, fat and fibrosis over time, where there might be an impact on the efficacy of the therapy?
Yeah, that's a really good question. I think with all interventions, the earlier that you intervene, the bigger the signal that you can have, right? But even in later stage individuals with Duchenne or Becker, they still have muscle, and there's no reason that we can't protect that muscle. The dose response may be different, but we fully intend to explore the potential for the compound in all types of patients.
Great, thank you. And Paulo, so I know that although that slide was a little bit off, it did show that there was, from your phase 2 and your open label extension, that with the addition of steroids, there was some additional delaying of disease milestones like loss of ambulation. Have you been able to explore any respiratory or cardiac function as well, or plans to track that in the future to see how those disease milestones may also be potentially delayed with the use of givinostat?
So, Eric, first of all, let me tell there, obviously, there is a non-demand video which is actually telling the whole story. So if anybody wants to go and look at that, they will see the full data set. The quick answer is yes. We have been looking at the respiratory function regularly. And what we are seeing is that if we look at the forced vital capacity percentage predicted, The decline is approximately 2% per year, and you probably know that based on natural history, we are usually talking about 5% loss per year. And if we look at the PEF, so the peak expiratory flow, which is in essence an assessment of the respiratory muscle function, while in the natural history you see and also here a decline of approximately 5% per year, we see no decline. And this is, as I said, in the 8th year of treatment with givinostat on top of steroids.
Great, thank you. And this question for Alan, with Edgewise, as you're looking, can you, I guess, explain a little more what kind of biomarkers that you're going to be looking at within the smaller study where with the Becker patients are being included? I know it's largely with some healthy volunteers, but what all Edgewise is kind of interested in trying to capture?
I think most of us are familiar with creatine kinase. That's a biomarker that's been talked about a lot. I'm personally a fan of looking at aggregate biomarkers of muscle injury. So we're looking at other biomarkers such as myoglobin, such as the troponins. We published a story on the troponin subunits secreted into circulation in Duchenne and Becker patients in muscle and nerve this year, which is kind of interesting. And we're also relying quite heavily on the SomaScan strategy that you guys really took forward first in Duchenne. They've now expanded that up to 7,000 biomarkers, and we're doing some really interesting studies right now to explore the role of proteomics to give you an idea of muscle injury.
Great. Can I ask a follow-on question in regards to this population of Becker? Well, first I want to say that you're all looking at patients with high unmet need, and I want to thank you for that. Whether it's non-ambulatory patients or Becker patients, these are badly needed for clinical trials, et cetera. For Edgewise and Intel Pharma, and we start with Paolo, can you talk about the Becker populations in terms of the functional endpoints that are being used and being explored in the future? The fact that we may not have as robust natural history data and sort of the challenges with this population overall?
So, Ryan, you're touching a very important point because clearly in the Becker population, the wealth of knowledge that we have in Duchenne by now is not there. So as you will hear on Saturday, obviously the study we have conducted was in essence an exploratory study, not only looking at what givinostat is doing in this patient population, but also learning more about how one can actually conduct a study in a Becker population. Mm-hmm. I mean, my first impression, and we really have preliminary data, top-line data at the moment, and we'll have to do much more analysis, but it looks like all the tests we are very much used to, like the 6-minute walk test or the time function test, may not be ideal actually in this population. There is, we have seen in our study, this is something that we have read many times, there is a lot of heterogeneity. So these are all factors that certainly will count when conducting a clinical study.
Yes. And Alan?
Yeah, it's, being able to explore the approach in Becker is really a great pleasure. And we've had a few different focus sessions with Becker individuals, and it's been such a joy hearing about their stories and how much, in many ways, they feel underserved by us, essentially the industry or community. As Paolo said, it's a highly variable myopathy, right? However, studies have been published recently looking at longitudinal history of change in these in Becker, particularly that of Luca Bello, and it does appear that you can potentially ring fence individuals that may be more likely to progress. We're hoping to get a lot more information on that by conducting a natural history study in Becker individuals. So we'll be kicking that off in the near future. That will hopefully inform endpoints for medicines and approval. But it is an interesting area, and we really want to take our time to find the best ones.
Great. Well, thank you all for joining us this evening. We really appreciate the discussion. We're going to move on to our next Pat Chat, where Pat is going to be joined by Dr. Krista Vandenborn from the University of Florida for a deeper discussion on muscle and imaging. So, Pat.
Thanks, Eric. I'm really thrilled to be speaking to Krista tonight, and really appreciate you taking time, Krista, from your busy schedule. I know imaging has kept you out of trouble these days, right? So first of all, congratulations on your renewal by the NIH for imaging. It's such an important study. So I'd love for you to just lay the groundwork of imaging. I often think of imaging as the 3 sites in the U.S. Tell me about those 3 sites and how you've thought about how you have expanded your interest way beyond the United States.
Hi, Pat. First of all, thank you very much for spending some time with me today. And I'm just delighted to be part of the PPMD conference again. I really appreciate it. So imaging DMD has grown a lot over the last 10 years. As you know, we started out with 3 imaging sites. There was our partners in Portland, Oregon Health Science University, Children's Hospital of Philadelphia, and then University of Florida. But we've really expanded very broadly. We've really tried very hard to move a lot of these measurements across many different sites. And at this point, we have about 30 imaging sites across the United States and Europe that are collecting data in the same way as we have in our original study. So a lot of expansion, and really with the goal to be able to run and introduce MR imaging into clinical trials.
Yeah, thank you, Krista. I know so many families over those 10 years that have participated twice a year, and really, first of all, look forward to your wonderful staff in participating. A couple things. I know at first when you started out, you were imaging the quadriceps muscle and basically the lower leg, and now you're looking at many more muscles, the trunk, the upper arms. Are you seeing differences, significant differences in how these muscles are changing over time?
That's a very good question, Pat. We've learned a lot, as you know, by having the opportunity to work with so many families that really helped us understand the disease and how the disease affects different muscles. So whereas we collected about 10-year natural history data in the lower extremity muscles, we've expanded to the upper extremity muscles. We're also measuring the respiratory muscles, particularly as the boys get older, we know that it impacts their pulmonary function. And so we really need better measurements there as well. What we've learned is that this pattern of fat infiltration happens across the different muscles, but the rate at which it happens is different. The reason that's really important is that, as you know, we're trying to use MR as potential biomarkers in clinical trials. So if we're looking at younger age groups, then maybe the quadriceps is a better muscle to target. But if we're looking at older boys that are non-ambulant, then there's other muscles such as respiratory muscles or the upper extremity muscles that may be much more valuable. But at the end of the day, what's really important is that this measurement of fat infiltration seems to be a really good measure of disease progression and a valuable endpoint that we can potentially use in clinical trials.
So I think that you're on the process to qualify fat fraction as a biomarker. So are you qualifying, so where are you in the process? And second question is, in terms of, are you qualifying that in a particular muscle or, across the board in terms of many muscles?
Yeah. So what we're doing right now is we're really building on all of the natural history data that we have collected. Our richest data set are in the lower extremity muscles. So for our efforts to move forward in MR biomarker development and qualification, it's really important that you have a rich data set. So our focus has been on fat fraction in 2 lower extremity muscles. That's the vastus lateralis, which is one of the quadriceps muscles, and then the soleus, which is one of the lower leg muscles. So we put together a steering committee, which is an MR imaging steering committee, which has representatives from PPMD, from industry, from NIH, and from academia, really working together to understand the data, and then collaboration with CPAD, that is our our partner to look at the regulatory component, we're submitting an application, a letter of intent right now to the FDA. So a lot of work has gone into it, and our primary focus right now is the lower extremity muscles, just because that's the richest data set that we have.
I see. So Critical Path has the DRISC Consortium. So this is a consortia that has a number of data sets within it, looking at disease progression models and trial simulation tools. So can you tell me a little bit about the path to qualify this? Is it, I'm sure it's very complicated because it's an FDA qualification, and so that takes a period of time. But at the end of the day, when we're looking at gene therapy as an example, one of the questions is, how are you going to get that approved, and what does it mean in muscle, and how will we know? Because obviously it was based on people who were doing very well from birth to their very older ages. So this microdystrophin will be hard to figure out unless we have such a validated tool to say the fat fraction has not changed or has changed, or the rate of change. So can you give us a timeline of that, Krista, and what you see into the future?
Yeah. You're absolutely right, Pat. It's a complex process. It's been a lengthy process. So I'm certainly by no means the expert in regulatory approval, and our team is learning as we go as well. But certainly our partnership with Critical Path and DRISC has been really, really important. They have a lot of experience in this area. So our first step is a submission of a letter of intent, which has been pretty much completed and is ready for submission to the FDA. At that point, we hope to hear back from them. So what we're actually submitting is a letter of intent for a fit-for-purpose application that allows us to really submit data and submit a briefing document that describes the trajectory, the disease trajectory of fat fraction and its relationship to function. What has been really important in the work is not just that MR is sensitive and it tracks disease progression, but ultimately that it is closely related or is associated with functional endpoints, and it can predict future function. So in collaboration with Bill Rooney and Sarah Kim and others, we have really invested a lot of effort to understanding how well MR biomarkers predict future changes in function. And that's ultimately really important because the MR measurements will tell us, hopefully quicker, that a drug may be working or not, but you ultimately want to know that that has functional implications. And that's really what the goal is of this project.
Great. So, and Krista, the study is still open for people to join this study, is that right?
So right now, the study was renewed over the last year. We have changed the direction a little bit in that the sense that we will continue to develop these measurements. We're focusing now more on respiratory muscles in non-ambulant patients. As you know, that is a group that particularly is in need of more outcome measures. And then, and follow up to some of the discussions earlier, we're also looking at Becker's patients. There is a real need to understand the natural history of Becker's as well as having more measurements. So that will be the focus. So we've expanded. We are looking at both Duchenne as well as Becker's patients.
And you're also including female manifesting carriers?
Yes. We are doing a separate small study that is going to focus, thanks to your support, Pat. We really appreciate that. We are going to be looking at female carriers. We've done a little bit work, but we're going to expand on that as well.
Good. Krista, I'm really so thrilled about imaging DMD and what it can bring to this community. A highly sensitive biomarker that really can predict function, that isn't biased, right? That isn't based on someone's opinion. And I think that your work in both ambulatory and non-ambulatory and Becker, and certainly manifesting carriers, is remarkable. So we're thrilled to be a part of imaging, and for anyone listening, joining an imaging study I think is so critical to progress. I can't thank you enough for spending time with us tonight. We so appreciate all of you, and your team is such a great team. It's a pleasure to work with you. And so next year we'll be together in Scottsdale. So thank you very much for joining us tonight, Krista.
Thank you, and thank you to all of the families.
Thank you. Back to Ryan and Eric.
Thank you, Pat. Thank you, Dr. Vanderborn. Now we're going to turn to our next panel about the power in advocacy. As Pat mentioned, this year marked 20 years since passage of the MD CARE Act. This really was landmark legislation for the muscular dystrophies. It ushered in a new era of federal investment into Duchenne and Becker and truly changed the landscape. And it really has been because of patient advocacy, families advocating across the country with their members of Congress, creating champions, as well as creating relationships with those at the federal level. Here's a word from some of those champions before we begin the next panel.
I joined this battle almost 20 years ago when a fellow Mississippian told me about his son's diagnosis with Duchenne. That led me to introduce the MD CARE Act, which dedicated the first federal research dollars for DMD.
The MD CARE Act galvanized the Duchenne community. It shifted the global conversation. It changed outcomes for Duchenne and the other muscular dystrophies. And most importantly, it demonstrated that every voice matters.
Not only do we just need research at NIH, we need patient advocacy. We need to hear the patient voice. We need to understand how people feel and what matters to them about the disease and how we can best track the progress in improvement with treatments.
I think this is proof of concept that advocacy really matters, but also convening people across a variety of sectors to focus on an important problem and really move the needle on the dial gives us hope that we can do the same for many other conditions.
Treatments and cures take time, but we have made progress. We have done it together, and I can tell you none of this would have gotten done without all of you and the people before you and the people that never gave up, either fighting for themselves, for their family members, for their neighbors, and for people they don't even know.
Every patient, every advocate, and every member of the support system shows courage, shows resolve, and moves the needle forward. My message to you is simple. Keep it up.
I intend to keep pressing forward in the fight against muscular dystrophy. There are still challenges ahead, but the gains we have made hold the promise of even greater breakthroughs to come, and one day, a cure.
Those voices you just heard were moved to action because of families advocating and telling their story. Today, we have an incredible group of family members, all advocacy captains from across the country, who are here to talk about the power and importance of advocacy. Joining us today, we have John Killian, Patty Elder, Ravi Littman, Jessica Fabus, Colin Worth, and Colleen Lavadia. Thank you all so much for joining us. We're thrilled to have you here to speak about the power of advocacy. And I'm going to start with John Killian because he's in the middle square there. So I'm going to pick on him first. John, howdy from Texas. As they say, this isn't your first time at the rodeo when it comes to advocacy. You've been doing this for many years. You like all those Texas references, I'm sure. Can you talk a bit about your experience in advocacy, why you got started, and what it's been like?
Yeah, thanks, Ryan. I'm just realizing actually that when I started advocating, I was the same age I think you are right now. So I'm feeling kind of old. So when our son Sam was diagnosed in 2002 or 2003, I started just looking around and realizing that the MD CARE Act had been passed, but really hadn't sort of kicked in, and so the impact hadn't really been felt. And so in those early years, it was really just about finding funding for research because there just wasn't that much going on, and certainly funding for the NIH and other organizations in Washington was really lacking. And then over the years, as we started to see more funding for research and the impact of the MD Care Act and the Wellstone research centers and those kind of things, we realized that one, we were having an impact, and two, there were so many other things that we needed to have an impact on, things like care considerations, and now I think especially the focus on the FDA and how we get all of this research that's been funded and all these companies that are working on our behalf. How do we get those things through the process? And we're having an impact there too. But like they said in the video, there's much more to be done. So we got to keep going back.
We can't put our foot off the gas. I mean, I think advocacy is a marathon and not a sprint, and it's about relationship building over time, which you all have been such a big part of. So Ravi Littman from Tennessee, could you tell us a bit about why you got started with advocacy and your experience over the years?
Hi, Ryan. It's nice to be here. Thank you for inviting me on the panel. So last year, I was my first advocacy conference back in March before COVID shut everything down. So I didn't know what to do. I didn't know anything about it. I had recently joined the PAC, which is for patient adults, their voices and stuff. So I recently been involved with that, and I was interested in advocating for patients with DMD because I had never done it before. I was nervous, of course, which I am kind of now, because I didn't know what to expect. And obviously I'm no policy expert. And I never met my congressional members in the House or the Senate. But thankfully, Patty Elder, who's also on the panel, she warmly welcomed me and even helped guide me through the meetings with my representatives, even though she wasn't even from the same state. So it was truly a great experience and something I'll be doing hopefully for the coming future.
That's awesome. That's awesome. You're a wonderful advocate, I must say, and you're doing great. And I think we see advocates tend to pay it forward. Once they first get there, they're a little intimidated in their first year, but they pay it forward to other advocates and get them comfortable. Patty, you did that, and you've done that many times. Turning to you as an aunt of someone with Duchenne, tell us about your experience with advocacy over the years.
Thanks, Ryan. I actually got involved soon after my nephew Logan, who lives in Texas also, was diagnosed. Now, all of you who are in the Duchenne community are already advocates for your sons, your nephews, your grandsons, your friends. You advocate for tirelessly for him with respect to his health care, his mental and his emotional and social health, his education, his dreams for the future. And if you participate in clinical trials, which many of you do, or other research, including those PPMD surveys, you're helping to advocate for all of those who live with Duchenne, not just your special person. So by participating in the advocacy conference, you can help persuade others to be champions for the whole Duchenne community. You help spread the circle of awareness and support. And we're really making a difference. In the 11 or 12 years that I've been attending the advocacy conference, I've turned 3 of them into mini family reunions by inviting other relatives from other states to join me in DC to meet with their states, senators and representatives. But even if you can't make it to DC, you can meet with your elected officials on home turf, in their district or state offices, and PPMD can certainly help support those efforts. Or be on the lookout, I should say, and be on the lookout and respond to PPMD's emails and action alerts. Help us widen the circle of support.
Totally
it makes
agree.
a difference.
Totally agree, Patty. In many ways that we try to give you as many tools as possible, and I think that family members advocating is so important. It's a way to support your family, and we've seen many close friends as well advocate. So, Jessica, as another family member, talk a bit about what you've experienced and really the importance of telling your story when it comes to advocating.
Absolutely. I think among family members, sometimes there is this thought that, well, I don't have a son with Duchenne, or I'm just a friend, or I'm just a colleague. In my case, I am just a cousin. I'm also a carrier for Duchenne. But I will give you a great example of what the power of your story is as just a cousin. And a couple years ago at the conference, I had to actually talk to one of my house members on my own. And it was a moment where it's like, this might be a little scary, but I'm going to work through the fear and I'm going to do it anyway because of the importance of what we're here for. And I went and I spoke to a young woman, staff member of one of my representatives, and I told her my story. I told her that I was a carrier. I told her what Duchenne was and why it's so important that we continue to have research and funding. And, long story short, the member did sign on, first-time member signing on, but that wasn't the takeaway for me. After I told my story, she said to me, "Thank you for telling me that. I had no idea that Duchenne could come through the female line. And actually, I have family members years and years ago who had Duchenne. And she had no idea that that was a possibility. She was someone who was about to get married, who was considering having a family, and now had that information. So when you tell your story, it's not just getting House members, senators to sign on. Yes, that is our goal. You don't know who you're telling your story to. You may be touching someone in a way that you had no idea you can change the trajectory of someone's life. So that's what I did as just a cousin.
I think that's amazing, and it's so true. And Ravi, you touched on this before too, that you don't have to be a policy expert. We're not expecting you to know legislation through and through. We're expecting you to be able to tell your personal story, and you'll have support from those who are seasoned advocates, like those who are on the line. Just a reminder, Jessica's from New York, Patty's from Maryland. I think I've named all the states, but these folks, if you're in that state, they can help you as well. Shifting now to Colleen, we went virtual this year, which was a very positive experience. Face-to-face advocacy is very important. I should stress that we're going to have to continue that. But Colleen, tell us about that experience. Give us a little background on your history as well.
Sure. Well, I'm from Florida, and we have a lot of ground to cover here. The advocacy conference has become one of my favorite things to do every year. Goodness, it's been 6 or 7 years now. I've headed to DC, and I'm a people person. I love face-to-face. I love giving hugs. So I certainly miss that aspect of it. But Florida really stepped up to the plate this year when it came to the virtual component of it. We had a lot of people come forward who haven't been able to get to DC, but now that they've taken part and they've been experienced to what the advocacy conference is all about, they've gotten bitten by the bug, as they've said. They've really become accustomed to what we do. They realize you don't have to be a policy expert. You don't have to be a poli-sci major. You just need to go and speak with our lawmakers and let them know your story. Make that personal connection. And that truly is the key. When you sit there as a parent, a grandparent, a cousin, as Jessica said, all of a sudden that story or that statistic becomes real. You are living this. And so many times these lawmakers jump in and ask us question after question and really want to know. And it's nice when you follow through and you send an email to say, thanks for meeting with us. Sometimes you don't get a response, but when you do, it's really nice. And when they remember, hey, give your best to my son. I hope he's doing well playing t-ball or what have you. It's really important. And you've connected with them on a different level rather than here's our folder. Thank you very much. be connected definitely at a different level.
Yeah, I agree. And I think that at the end of the day, this is relationship building. I've said that before. I'll say it again. And you have to be consistent. We're proud to boast that we have the longest running rare disease advocacy conference in the country. It's because of all you. Colin, we're going to end the panel with thoughts from you. You've been advocating. You've been galvanizing the other advocates in your state. You're also a PPMD Connect captain. Tell us your thoughts. If you have a message for other advocates who may be thinking of advocating but haven't taken the plunge, what is your overall message to them and how you feel about advocacy?
So, yeah. Hi everyone, sorry. So I think it's just whatever, I would just say whatever way you can participate makes a difference. So rather, whether in person or virtually, or even just sending an email or making a phone call to your representative's office can make an impact. And as everyone is saying, your sharing your story really makes an impact.
It truly does. It truly does. And I want to thank you all for all you do. Colin, I want to mention you're from Virginia, right in the backyard of Congress, and has been doing a great job getting people active in the advocacy conference. You all have. You've all inspired so many people. We couldn't do it without you. I could talk to you for another 30 minutes. I appreciate your time tonight, and I'll be looking forward to working with you more in the future. For those who are listening to us about this, if you've never advocated before, we have an action alert going out right now on the Benefit Act, and I hope you take the small step of taking that action alert online, and we'll send more information about next year's advocacy conference, which will hopefully be in person. So hopefully I'll see all of you in person. So thank you, panelists. We really do appreciate it.
Thanks, Ryan.
Okay, so we are going to transition now to our first polling questions and pop quiz. Remember, the person who answers the pop quiz question the fastest will win a $25 gift card. Families will be the people that can only answer these questions. Please enter your full first name when asked before you enter into the polling. This way we can enter you into the drawing for the prize. So let's get our first poll question up. You go to pollev.com/ppmd to participate. You can open that up on another window. Many of you have done this before. If not, this is an important way to get involved and give us really useful data to inform the work we're all doing. And I think the first question hopefully is coming up. Again, it's pollev.com/ppmd. We just want to know, this is an easy one, what is the diagnosis of your loved one? You can answer multiple options here if you have more than one loved one in your family with Duchenne or Becker, maybe a female carrier as well as a female manifesting carrier.
Yeah, it's always a great way for us just to see who's all kind of tuning into the conference. And this is also where we would, make that plug as well for all of our mothers out there to make sure that, you go and get carrier testing. And, if you need help with that as well, it's something to connect through Decode Duchenne as well to help with that. We want to make sure that, everyone knows if they're a carrier and what their mutations are, as we're learning more about that population as well.
Yeah, it's just another area of unmet need that we've been trying to tackle now for many years, and we will continue to put out resources for. So it looks like a vast majority are male with Duchenne, and then we have nearly 24% female carrier of Duchenne as well joining us today. Let's give it one more minute.
And obviously we have, a lot of content for this group, but we do hope, as we saw in those discussions we had a little bit earlier in the pipeline, that not only are we going to continue to develop therapies for those with Duchenne, but also that those will, come on for patients with Becker, as well as our female carriers and manifesting carriers.
Great. I think we can get to the next question. Okay. This question is, what following types of research have you or your child participated in? You can choose all that apply.
And we do have quite a bit of options here as, there's lots of different ways you can participate in research. We always appreciate your participation. Without you, obviously, we can't move any of this forward in the field, whether that's natural history studies, whether that's the clinical trials with an investigational product, or even, responding to the surveys that we send out through PPMD. It all helps and it all contributes. So we do always appreciate that participation.
Yeah, I appreciated Patty plugging that in the last segment, because I know I'm one of those people that constantly ask you to fill out surveys, and they do matter. That information is sent to all stakeholders, the results of those surveys, to inform the work everybody's doing within the community, so we can't thank you enough. Right now we're recruiting for a survey patient experience study, so if you've received an email, please consider taking that. We're going to keep it open for 2 more weeks. So it looks like the vast majority have participated in survey research. We've got a decent percentage of clinical trial, of an investigational therapy, followed by natural history studies, including MRIs.
And if you're looking for more clinical trial information, we do have our Explore Clinical Trial tool on the PPMD website, as well as our interactive pipeline where you can learn more.
Great. We can move to the next survey question. Okay, this is for caregivers only. Approximately how old was your child when you first discussed the diagnosis of Duchenne or Becker? Some may be too young, in your view, to be talking about this at the moment with them, and that's okay. We do have tools online when it comes to this topic as well.
Mm-hmm.
Looks like a large percentage so far are marking between the ages of 3 and 4, and I found that anecdotally talking to families that age feels appropriate.
Yeah, there's a lot of families, it's probably around the time of diagnosis. We may have some, though, that depending on how your family feels about that, as you're kind of learning and living with Duchenne or Becker, about what that appropriate time is. And that is a decision for you and your family, and it's great, though, to be talking with your care team as well about when that's appropriate.
Exactly, and that's a very personal decision. These surveys are anonymous, and they're not going to be made public by anybody. We appreciate honesty on all the questions. It looks like the highest choices are between 3 and 4 and 5 and 6 years old.
And we do hope to continue to help find ways to get to earlier diagnosis as well. If families, want to have those conversations earlier, PPMD has a pilot program with New York State for newborn screening that we're hoping we can continue to develop, as Pat mentioned in her opening address.
Okay, I think we can go to the next question. Okay. Have you ever communicated with a member of Congress about Duchenne? This is I'm biased on this question, asking this after our advocacy panel. I'm just interested in your interactions. If you're not from this country, if you're from another country tuning in, you can answer this question based on your own members of your government and whether or not you've communicated with them about Duchenne at any level. It looks like a large percentage so far in the polling have.
And that's fantastic to see. As we've talked about, your communication with your leaders in Congress really does help move the needle. We've seen over the years, you can look at the funding line for what's gone into the Department of Defense as evidence of the change that you have made by those meetings, by those emails, by those phone calls. So we appreciate everyone's help in this.
Absolutely. And if you haven't before, please contact us. We'll talk you through it. We'll connect you with a mentor, someone that's done it before. It's a great opportunity. It's a very empowering opportunity.
It's a great way to meet other families in your state. I've had the opportunity to go, and although I do not have a loved one with Duchenne, I obviously get to meet all the great families in this community and help advocate on behalf of them as well.
Mm-hmm.
So it's a great way to meet your community.
Absolutely. We can go to the last question, which I think is the pop quiz question. Yay, the pop quiz question. This is. I didn't know the answer to this. What is the proper name for what we commonly call a hashtag?
Oh wow. Okay. I know one of these words, I think, or maybe the last one if I'm pronouncing it as well. But
yeah. I didn't know when I first saw this.
Yeah,
I thought some of them were made up English.
This one's harder than last year's.
It looks like a lot of people are narrowing in on does that say Octothorpe?
It does say Octothorpe.
A Marvel
I think I know
character.
one that it's not, and that's about as good as I'm going to do.
Yeah.
Yeah. It'd be like on Who Wants to Be a Millionaire. They take away the two that I'm certain are incorrect.
Okay, the winner of the polling for each pop quiz every day, we are going to be sending a $50 gift card. So we will tell you the winner at the end of each day. Okay, I think we've given everyone enough time. Let's see what the answer is. Hopefully that pops up in the end and Eric can show the actual answer. He's not able to? Okay, well we can actually look that up ourselves and provide the answer. I thought it triggered the answer at some point. Okay, Eric, do you want to take us to the next session?
Yeah, so next up we have our first in our recently reported update talks. So as a reminder, this is where we're going to have sponsors being able to share new data with the community, and we have at least one of these talks every day. I believe we have 2 scheduled for Saturday, so it's going to be quite exciting. So the first presentation is going to be from Dr. Paula Clemens, who is going to be sharing some of the updates from the open label extension of the phase 2 Philtexo trial. So Dr. Clemens, whenever you're ready.
Pleased to be here tonight. And I'm hearing actually an echo. Okay, better now. Really pleased to be here tonight and really thank PPMD for inviting me to do this presentation. I'm a professor of neurology at the University of Pittsburgh and have worked with an industry NSfarma on the study of Philtexo and was the study chair for their phase 2 studies. And what I'm going to tell you about tonight is the phase 2 extension study of Philtexo, which is an FDA-approved treatment for patients with Duchenne who have deletion mutations that are amenable to exon 53 skipping. Next slide. So I'm going to start by giving you just a brief background of the dose-finding study that led up to the long-term study results that I'm going to be showing you today. Next slide. So this study studied 2 different doses of Philtexo, a 40 milligram per kilogram per week dose and an 80 milligram per kilogram per week dose. 8 participants were enrolled at the 40 milligram per kilogram dose, and then that was followed by a second group of 8 participants at the 80 milligram per kilogram dose. And each of the participants was treated in what's called an open label, which means that there was no placebo control, except at the very beginning to test for safety, such that each participant in the initial dose-finding study had 20 or 24 weeks of treatment with Philtexo. Next slide. So the study had several endpoints. The primary endpoint for this dose-finding study was a biomarker study, and the biomarker was the expression of dystrophin in muscle. So these participants had a muscle biopsy at the beginning of the study before any treatment, and then they had a second muscle biopsy done at 24 weeks after receiving treatment over that period. Their safety and tolerability, as well as drug levels, were carefully followed. And then there were a series of secondary outcomes that I won't report on tonight. This is all studies that have been published. Next slide. So just to highlight the key eligibility criteria to be in the study, the participants were all between 4 and 10 years of age at the start of the study. They were able to walk independently, and they were all on a stable dose of glucocorticoids. There were a series of exclusion criteria just to provide for safety of the participants in the study. Next slide. This slide just gives you the baseline demographics to show that each of the two groups, the 40 milligram per kilogram group and the 80 milligram per kilogram group, were quite similar in terms of age, height, weight, etc. Next slide. And this is the important outcome slide that I'm going to show you for this dose finding study. We're showing here the 8 participants that were in the 80 milligram per kilogram dose and showing their pre-treatment muscle biopsy dystrophin level, as well as on the right side of the slide, their post-treatment dystrophin level in muscle biopsy. And so you can see that all participants showed an increase of varying amounts, but 7 of the 8 showed over or at 3% of dystrophin by the end of this study, showing that Philtexo did increase the level of dystrophin in muscle, which was the primary outcome that led to FDA approval on the accelerated pathway. Next slide. So with that as background, now what I wanted to show you as the new data tonight is the open label extension study. And so this, all 16 participants in the dose finding study had the opportunity to continue into an extension study where they received treatment, and all 16 participants chose to continue on in the extension study. Next slide. So again, just showing the graphic of the slide of the study schema, and highlighted in the white box there is just showing the extension phase for each of the 2 dose levels. Next slide. So the primary outcome for this extension study is a clinical outcome. It was the time to stand, which is the time required to stand from supine. And the secondary outcomes were the other typical clinical outcomes that are used in Duchenne clinical studies. And as always, safety was assessed throughout this open label study. Next slide. The primary inclusion criteria was simply that the participants had completed the dose finding study and were continuing on glucocorticoids. Next slide. So this is the primary outcome. And so let me just carefully walk you through this slide. The left-hand graph is showing the time to stand measured in seconds. And the right-hand graph is taking that same time to stand, but converting the measurement to a velocity by taking one rise divided by the number of seconds. It's just another way to represent the time to stand measurement. The Philtexo is shown in the navy blue line. And because this was an open label study and didn't have a placebo, it was compared to an external comparator. And that's shown in the tan line. Now, the use of an external comparator is important because it clearly needs to match the group that was in the open label study. And in this case, that external comparator group was taken from a data set that was provided by the Synergy Duchenne Natural History Study that many of you I know have heard of, and many of you I'm sure have participated in. And this is a prospectively collected observational data set. And what a study such as this can do is essentially take its eligibility criteria as a means of pulling a comparator data set from the observational study. And so it provides not as rigorous a control as a placebo, but certainly best control that we can provide for an open label study. So in the left-hand graph where we're showing time to stand in seconds, along the x-axis, you see the baseline and then progressive time points up to 109 weeks, which is the point where the data was pulled for this presentation. And going toward negative numbers is, of course, is improving in the seconds, because that means it takes less seconds for time to stand. And what you can see is that there is a significant difference at all time points, but certainly out at 109 weeks between the comparator group, which is not treated with Philtexo, and the Philtexo treated group, which is in navy blue. And of course, the direction of improvement reverses for the velocity. And so with Philtexo, you see an initial increase in the velocity of time to stand that then stabilizes as compared to the progressive decrease in velocity that you see in the natural history comparator group. Next slide. And this shows a very similar set of data for the time to run walk at 10 meters. Again, the seconds is on the left-hand graph, and the velocity is shown on the right-hand side, or the right-hand graph. And the navy blue line is the Philtexo treated. And you can see that there is an initial decrease in the seconds required, and an initial increase in the velocity with stabilization maintained over time compared to the external comparator group. Next slide. And finally here, just showing you the results of the 6-minute walk test. In the navy blue Philtexo group, you can see a stabilization in the distance walked in the 6-minute walk test. There is, in comparison, a slow decline in the untreated comparator group. Next slide. So this chart shows you the what are called treatment emergent adverse events. That means anything adverse that happens to a participant after the start of treatment. It doesn't have to be related to the drug, and so not unexpected for a 2-year time period with children. All 16 participants in the study reported adverse events, but only one child reported a drug-related adverse event, and actually that one event was the infiltration of an IV line, so not really technically related to the drug, but more to the procedure of administering the drug. Next slide. And so then this chart gives you an idea of what some of the adverse events were. And you can see there are mosquito bites, coughs, falls, headaches. These are the typical adverse events that we all experience through life, and not particularly deemed to be related to the study drug. So overall, the safety profile was really, has been really excellent with Philtexo. Next slide. So in conclusion, I am reporting to you that in this initial phase 2 study, the treatment with Philtexo in patients with Duchenne with deletions amenable to exon 53 skipping resulted in significant increases in dystrophin production as assessed by analysis of dystrophin expression in muscle tissue. But importantly, this correlates with a clinical outcome, such that using time function tests as markers of clinical efficacy, the effects of viltolarsen were maintained over this long-term study over at least 2 years, compared to a decline that we saw in the historical control group that was matched on all the key eligibility factors, for example, age and also steroid treatment. The safety profile of viltolarsen over the long-term study was similar to that observed in the initial 24-week study. And based on these results, we can conclude that viltolarsen is an important treatment option for patients with Duchenne who have a deletion that is amenable to exon 53 skipping. And with that, I would like to thank you all for your attention. I certainly want to thank the participants in this study, and I'm going to hand it back to Ryan and Eric.
Thank you, Dr. Clemens. Just add a quick question. We don't have time for a long Q&A, but that was very, very positive results, so we're excited to see that. Are we going to continue to follow these patients, and we'll have opportunities to, see this data even further out to see how the impact of viltolarsen?
We will, actually. In this extension study, the participants have the opportunity to continue up to 216 weeks of treatment, and then after that, they have the option to move into a further long-term extension study. At that juncture, the US patients are transitioning to commercial treatment and will follow with some continued collection of outcome measures, but hopefully trying to sort of progressively decrease the burden to the participants in this study. But we're really happy that a lot of the participants are able to continue in the study, and we'll give that really long-term treatment effects that we all want to see.
Oh, great. Thank you. And we'll certainly look forward to that. And thank you for sharing that data update with us. We greatly appreciate it.
Okay. Thank you so much.
Right.
Bye-bye.
Great. So I'm going to announce our daily photo winner for the photo challenge. We have Cole Terrell from Smithfield, Virginia. What a great job on today's challenge. Tomorrow's challenge, as you see, is going to be summer style. We've included even sunglasses in your conference box. So we had a lot of great participation in this. So we thank everyone. And Cole, way to go. That's an awesome picture. Also, can announce that the answer to the pop quiz trivia for that last polling question was Octothorpe was the answer. And that we'll be in touch with the winner for that was Leanna Laguzman from Houston, Texas. So in both cases, we'll be sending you a gift card. We thank you for participating. So Eric, what do we have up for tomorrow?
Thanks, Ryan. So tomorrow we have the start of our Lunch and Learn series. We're also going to have the first of our care panels where we're going to talk about the ins and outs of GI health. We're going to have another of our In the Pipeline session. We're going to be talking about the current gene therapy trials. And then we have another recently reported update presentation. And as a reminder, we do have the Zoom social for our teens and adult track. And make sure that you're checking your emails in the morning for an overview of the day's session.
Great. So with that, we want to wish you a good night. Sign off. I want to wish a happy birthday to PPMD's own Nikki Armstrong. And we will see you all back here tomorrow.